NCI collaboration, but there are various ways to look at it, in the sense that, like for example, Korea participated in an NRG oncology trial, basically that was initiated from the Korean side, and even the American institutions, academic institutions participated in that. So if you have an idea, trial idea, you can definitely become an affiliate member, like Tata is an affiliate member of University of Maryland for energy oncology. So you can submit your letter of intent to energy oncology, and this can go through all the way through the cancer therapy evaluation program at NCI to get the approvals. And that can be a protocol, an international protocol.
So we have a hope that with, on the shoulders of NCI, we might be able to develop regional protocols, and I think our association liver and other, and even Asian Pacific can help get benefit from you. Ganguly sir has some points.
Actually,
yes, sir.
This was an important question which you asked, and your institute itself has developed markers which show that whether the person is improving with these immunotherapies or immunocheckpoint inhibitors. So Dr. Mansoor's suggestion was very good with the kind of data which we have in ILBS, and some of the data I have recently generated, that we could develop markers. These markers they are mostly multi-omic markers. These could be used to see whether they are progressing or not progressing. One more question was asked, and I will like to answer that. That is, they are frightfully expensive. In some patients, they don't qualify for these. Even if you use, they will not respond. So they could be identified, and these should be used in only those who will respond in India point of view, because otherwise they sell all their home, hearth and everything, receiving it while it doesn't work. So this is a very critical question. This is a research question. There are now markers where you could show that this person is unlikely to respond. One last new development at Tata Memorial Center by Dr. Indranil Mitra, that some of the things which again your institute is working on, the histone and the circulating chromatins, which infect the bystander cells, and the cancer metastasis goes on. So they have now found a method which now drug control has approved. The trial is going on, the versatile with the copper combination. So there are more and newer development happening, which could be India specific, but as Dr. Mansoor suggested, that we need to join these available consortiums, and with our data which we have generated, we should join them and develop more protocols.
Resveratrol is a great idea, and we have not utilized it enough. Thank you, sir, and also your suggestion of cell-free DNA and markers in the liquid biopsy. I think we work together on that, and that could be cheaper and maybe more reliable. Dr. Mansoor.
HCC is a global problem. IAEA is significantly interested in having combined modality trials. I think they are opening several trials also. Probably that's another area to participate in low-cost trials, and which will not cost you that much probably.
Thank you. Yes, doctor. And meanwhile, we have last 2 minutes left. Anybody who has a desire to pitch in to make this a better, affordable and accessible care for liver cancer, please raise your hand or come to the mic in last 2 minutes. And Dr. Rewari.
Sir, I think WHO collaborating centers like ILBS and others, they need to really work with WHO in proper sequencing of these therapies. That is important not only in terms of when to start and also in terms of patient acceptability. That is a very important area that we need to consider. Besides cost, also in terms of grade 3 and 4, we saw almost 56% of patients having severe adverse reaction. So those kind of things are things which WHO collaborating centers like yours we can work closely at WHO in the guideline development group. How do we position these immunotherapies overall care? Thank you.
All right, we have Professor Nirupma, you want
Sir, I wanted to say that if we want the Indian data, so all the centers are working in the cancer, but we don't have the, we need to put together the all scientific data, as Dr. Ganguly said, that the different institutes are doing, and the brainstorming, if we can do, we can certainly come up that in the liquid biopsy or in the tissue, what are the markers and how we can utilize in India. At least we can start it.
Okay. We may have a comment from Chandan, who is the vice chair at Montefiore Cancer Center, one of the best known radiation oncologists in the world. Chandan, any guidance?
Yeah, so, I mean, you were talking of biosimilars, but Fabio, what the point is that if you have an alternative, you have made antibodies to EGFR, for example. So you could be making soluble PD-1 receptors, which are similar to antibodies but in a different mode. The issue is we need to know in ILBS, if you want to develop such a thing, what are the next steps?
So we have alternatives and we could think, certainly with your guidance. Now the time is running out. You have a last burning suggestion.
Yeah. So, sir, actually I think we also have to look at from health economics, what is most important, and do we involve health economic experts also in our decision making when we are doing the research?
I am a health economist. If I have money, I will get the treatment. If I have no money, I'll change the doctor.
Yeah, no. Sir, what I was trying to say is, how can we have an early diagnosis so that
1 lakh rupees for an injection and you keep giving it for 20 months or so, I mean, it is exorbitant. Anyway, I'll sum up this session by just saying, today was one thought, and we thought we would corner DCGI, but we were unable to corner DCGI and also the other pharma to get themselves engaged into this discussion. I have my friends around, but I personally get committed today with this session that we will change the scenario. We will try and develop our own TKIs at a low cost and our own ICIs and new molecules and new drugs. With that, I want to thank everyone, all the panelists, and all of you. Despite lunch hours, I know you didn't get adequate lunch, but that's all. Food is thought, and thoughts are food. Okay, thank you.
Hello. Thank you, sir. Now let's move on to this next session, session 12, HCC and non-cirrhotic liver, that dilemma. I would like to invite the chairpersons, Dr. Vivek Vij, liver transplant surgeon, Fortis Hospital, Delhi NCR, Dr. Ajay K. Jain, head department of gastroenterology, Clothram Hospital and Research Center, Indore, Dr. Ragini Kalimbi, associate professor, Department of Surgery, ILBS, New Delhi, Dr. Amit Mandot, senior consultant, hepatology and liver transplant, Global Hospital, Mumbai. I would also request the moderators, Dr. Sudmanshu Kesi, Professor and Head Department of Hepatology, National Academy of Medical Science, Bir Hospital, Kathmandu, Nepal. Dr. Mukul Rastogi, Senior Consultant, Department of Gastroenterology and Hepatology, Fortis Hospital, Noida. Dr. Sudhanshu Pargewar, Consultant Interventional Radiologist, Global Hospital, Mumbai. Please join us on the stage.
Good afternoon. In this session, hepatocellular carcinoma and non-cirrhotic liver, the dilemma, the first speaker is Professor Vinendra Pamicha, Head Department of Liver Transplant and HPV Surgery at Institute of Liver and Biliary Sciences, New Delhi. Professor Pamecha.
Thank you very much. I'd like to thank Professor Sari and Ashok for having me here. So what I'm going to do is, next 10 minutes, I'm going to talk about resection for large hepatocellular carcinoma, non-cirrhotic. We'll see how non-cirrhotic these are. So there is no clear definition of large HCC. Previously, it was about 5 centimeter, then literature comes across about 8 centimeter, and then people classify 10 centimeter as giant HCCs as well. Size as such is not a limiting factor for liver resection, but it is an important prognostic factor, likely because of incidence of macrovascular invasion and distant metastases are related to HCC size. Large HCC and major hepatectomy previously was considered to be in high risk, but because of improvement in surgical technique and perioperative care, the results are very good, and now we rarely see a perioperative mortality for resection for HCCs, and the overall outcomes have improved because of the improved surgical techniques as well. So these are just the data basically summarizing in terms of what are the results of resecting HCCs, overall survival and recurrence-free survival. So the 5-year survival goes up to 56% and recurrence-free survival is about 35%. That's globally. And within Asia, again, 5-year survival is about 57% and recurrence-free survival is about 35%. So the reason to classify Asia separately is because it's well known that we see more large HCCs on the background of hepatitis B, and that's why maybe there is a difference. But overall, the outcome looks globally and within the Asia similar as well. When we look at large HCC, means when the tumor is more than 10 centimeter in size, then there is a difference in 5-year survival and 10-year survival with the size, increase in the size. So if you have more tumor with more than 10 centimeter size, the survival is lesser, and the 10-year survival actually approaches about 10% in those group of patients, and with 5-year it is about 23%. So this data is interesting to look at as a resection, as a modality of treatment for HCC, that as the time goes by, the survival keeps decreasing. And that's because there are two reasons. One is about recurrence, and other is also because they keep on developing chronic liver disease and they decompensate as well over the time, and that's how they die as well. So that's why the longer term survival, when we come to 10 years and more, the survival is around 25% with the large HCCs. So what is the change which has been seen is, previously we used to see many patients within their 30s and 40s with coming up with large HCC, and they were mainly on the background of hepatitis B. But what we're seeing nowadays is more and more patients with HCC, they are beyond 60 years of age, and they are associated more with NASH and MFLD rather than with hepatitis B. So that's the changing spectrum of HCC we are seeing. And that actually brings in the complexity of managing this patient, because they will have associated comorbidities like diabetes, hypertension, and cardiovascular diseases as well. So then again, just to mention about fibrolamellar HCC, because this is seen in younger age, it's a rare cancer actually, don't see much of it. It is higher incidence in the woman, mostly occur on the background of non-cirrhotic liver, and it does have a good 5-year survival of more than 50% as well. And it has, in general, it has got a better prognosis than the HCCs which are seen on the background of hepatitis C or hepatitis B and NASH as well. So this is again an interesting data on our own data on etiology of HCCs, which has been changing. So previously, most people would have thought non-cirrhotic background of hepatitis B, but now we see more commonly MFLD or NASH on the background. And that's where the complexity of the management comes in. So this is the changing spectrum. This is our own data of about 124 patients, which has been dissected over the last decade or so. Again, when we say non-cirrhotic, and I keep worrying about using term non-cirrhotic, because when we look at the background histology of most of these patients, there will be some form of inflammation, steatohepatitis, or fibrosis in most of these patients. So if you look at only 10% of them actually will have completely normal background liver, normal liver on histology. So they will either have fibrosis or chronic hepatitis or higher degree of fibrosis as well. And that's an important thing. So it's very unlikely that an HCC which develops on completely normal background, it doesn't happen. So it's not really good to classify them as a non-cirrhotic, because they will have some form of background liver disease, underlying background liver disease as well. This is just to show our own survival data on HCC resected over the time. The 5-year survival actually approaches about 50%, and the recurrence-free survival is about 42%. And when we classify them based on 5 centimeter, less than 5 centimeter, and more than 5 centimeter, again, although not statistically different, but obviously lesser the size, better is the survival. The 5-year survival with less than 5 centimeters is about 70%, and with more than 5 centimeter, it is about 43%. And when we look at recurrence-free survival, the 5-year survival is 47%, and with less than 5 centimeter, and with more than 5 centimeter, it is about 41%. So the size do influence in terms of whatever the outcomes of these patients are going to be. And this again, just to put it, most of the patients whom we have resected have a large HCC. About 95 of them had HCC more than 5 centimeter in size. Again, breaking down to less than and more than 10 centimeter, again, the survival is influenced by the size. More is the size, then lesser is the survival. But still, you get a good survival of about 50% at 5 years, even in patients who have tumors more than 10 centimeter in size. And then you compare this with other modalities of treatment like TACE or other loco-regional therapy, the survival is much better with liver resection than those loco-regional therapy. So this is just to compare with propensity matching on TACE versus liver resection, and significantly better longer-term survival with liver resection compared to TACE. And one of the queries which always comes is about remnant volume when you are resecting large HCC, and people keep discussing about how much amount of liver you're going to leave behind. So this is just about one of our case, 49-year-old lady, ECOG1, child A, large HCC about 17 centimeter in size, involving right lobe and segment 4A as well. Her alpha-fetoprotein was about 200, platelets were good, bilirubin and albumin were normal. And when you do volumetry, just to remember this, whenever you're doing volumetry, you need to exclude the volume of the tumor. So in her case, the total, if we take along with the tumor, it was about 1700 ml. When we reduce it, the tumor volume, it was about 1000 ml. So the remnant was about 24%. So we went ahead and did a resection on her. She did well. So when you're calculating FLR, it is important to remember that FLR more important than the volume of resected parenchyma. In a normal parenchyma, you can go up to 25 to 30%. In steatohepatitis, up to 35%. And when you have cirrhosis or severe fibrosis, you need to leave a remnant about 40%. So FLR calculation can be done by manual or Marian software. And when you're going to do portal vein embolization, it can also give you an idea about how the remnant is going to behave. So this is just her intraoperative photographs of resection extended right with chordate lobectomy, R0 resection. And she's now almost 8 years from her resection. She did have recurrence, but then she went on to have RF ablation, and she's still alive after her resection. So again, when you have low remnant, the modalities which you can do is you can do a portal vein embolization along with TACE, and which can actually induce the hypertrophy of the remnant. So in this case, again, because of the low remnant volume, the left lateral segment was about 100 ml or 100 cc or so. So we went ahead and did a portal vein embolization. Now the important thing to remember here is if you are going to do a portal vein embolization, then you should combine it with TACE. And there is good data now to support that if you do an isolated portal vein embolization, then there is increased chance of recurrence after the resection. So in this particular case, we did a TACE. There was good response to TACE and portal vein embolization. The tumor markers also came down, and his ICG was 6%. And then we went ahead and resected this, and this is almost 2 years from resection, and is doing well. So this is just to show the data, the difference between the survival with not having done TACE along with portal vein embolization versus portal vein embolization alone, and it clearly shows there is a survival benefit in terms of recurrence as well. So large tumor, again, I keep coming across this thing. People tend to measure portal hypertension with HPVG. Is that my time up? Yeah. Okay. So, can I get to my summary slide then?
Yeah. You can conclude it.
Okay. Oh, it's showing now. Okay. So, HPVG, because one of the things with HPVG is in large tumor, you can get a fallacious reading, and that's why you need to be careful, because if the tumor is compressing on the vein, that it's not going to give you a right reading, and then patient who can benefit from a resection won't be able to benefit from resection. So this, PVTT is again, there is no contraindication in V1 and V2, that is segmental and sectoral portal vein thrombosis. Upfront resection can be done and you can achieve good result. And in V3, V4, you should combine it with loco-regional therapy. Can I just get to my summary slide? If you can just show the summary slide, I'll finish it off. That was the last case actually. Okay.
Can you help him?
Last.
No, they do not have the approval, Vinendra.
Oh, okay.
So you have to speak on your own.
No, that's okay. So I'll just finish off here. So large SCCs are common, and resection is a good modality of treatment. In patient who cannot have an upfront resection, loco-regional therapy can be tried and downstage, especially in patients who have got portal vein thrombosis associated with it. And then sometimes you can see good response to portal vein thrombosis, and they can have a good longer term survival as well. So thank you very much. Thanks a lot.
Thank you, Vinendra. Can you join us here? We'll maybe at the end of the session, if we have some time, we'll have some question answers.
So next we'd like to welcome Dr. Santosh Poyamuli, who is a consultant intervention radiologist from Kowe Medical Center and Hospital, Coimbatore, to talk about loco-regional therapies, rationale, modalities and outcome for HCC in the absence of cirrhosis.
So good afternoon one and all. So we'll be discussing over the next few minutes about loco-regional therapy in non-cirrhotic patients with HCC. I represent team intervention radiology from KMCH, and headed by Dr. Matthew Cherian. So what is the problem statement? HCC non-cirrhotic accounts for around 20% of the overall HCC numbers. The presentation is late. Lilats doesn't apply, so biopsy is must. AFP elevation is not so common, and most of these patients have a very good hepatic reserve, so tolerance to surgery and LRT is better. There are plethora of guidelines which have been recently updated. I'm not going to discuss all of them, but everything is based on this BCLC 2022 classification, which is general for both cirrhotic and non-cirrhotic HCC, but it is a little biased towards cirrhosis. The difference is that transplant, which is a cornerstone curative treatment in cirrhotic HCC, is not anymore the curative treatment for non-cirrhotic livers, whereas resection is the best treatment for non-cirrhotic HCC. So how do we choose a strategy for a particular patient? We aim for cure because in keeping with recent times where curative therapy is promoted more and more for HCC of any stage, cure is the intention of treatment, and any other treatment has to be aimed for downstaging to curative therapy. And the best treatment strategy, as we have seen, is liver resection, liver transplant only for patients who are at risk of decompensation with resection. And all other patients who are unresectable and have extensive disease should be offered loco-regional therapy to either achieve a curative intent or a downstaging intent to curative therapy. Macrovascular or extrahepatic spread goes for systemic therapy, and if the patient is not fit for any of these former therapies, the patient has to receive supportive care. Now, ablation has very good evidence in very early stage and early stage cancers, which are less than 3 centimeter and up to 3 in number. The evidence is overwhelming for RFA, but microwave is equally, if not more effective. As we have seen, it can give rapid ablation, more ablation zone, as well as less of heat sink effect. But the studies have been equivocal that both are equal in survival and complications. But the trend of therapy, choice of ablation is moving towards microwave in most centers. There is very less evidence in non-cirrhotic livers, but I could pick up one paper which showed that resection is better than RFA for most patients who have solitary tumors less than 5 centimeter. The only point where there was equivalence was in tumors less than 2 centimeter and age more than 65 years. This is a subgroup where RFA as well as resection was having equivalent survival. In all other groups, the survival was better with resection. Another point to consider here is whether the small tumor is in the central liver or on the peripheral liver. If the tumor is in the central, it needs a major resection, and ablation offers a less morbid alternative. Whereas if the tumor is in a peripheral location, the small tumor, it can be treated with a local resection, and the surgery is not that morbid. These patients should have resection as their first choice. Of course, ablation is not without limitations. Lots of locations where the tumor is close to diaphragm or other organs or close to the vascular biliary structures, we are limited. We have techniques to overcome them, but most often we go for treatment stage migration, which is recommended by the BCLC. Tumors larger than 3 centimeter but less than 5 centimeter will definitely benefit from combining with TACE, because several studies have shown relatively better overall and recurrence-free survival in this group of patients. A new technique which has been showing some interest is combination of balloon TACE along with balloon occluded microwave ablation, where a balloon microcatheter is placed in the feeder distally close to the tumor. It is inflated after the microwave probe is placed, then the ablation is done. The logic is once the balloon is inflated, the blood flow stops and the peripheral blood flow reverses, leading on to larger ablation zones. And when it is combined with the balloon occluded TACE at the end of the procedure, it gives an effect like a radiation segmentectomy, and we achieve a near curative response. In 91% of the patients achieved a complete response after this procedure. It's coming up, the evidence is not much, but it is a very new concept which needs attention. TACE doesn't find any specific mention in the literature in non-cirrhotic liver, so we go with BCLC guidelines and then extrapolate it. TACE as a primary procedure is recommended in BCLC-B in select group of patients who have well-defined nodules and whose arterial access we can selectively cannulate, and these patients should not have portal vein obstruction. Whereas it can also be given to patients of earlier stage if the ablation or resection is not feasible. So this slide I want you to have a look. It is a recent concept published from Japan by Professor Miyayama, where they say that the peripheral part of a tumor will receive some supply from the portal vein, and arterial therapies which target only the arterial end of the lesion or arterial side of the tumor may result in peripheral residual tumor which are bound to have more aggressive biology after the session of TACE. And also the changes in the hepatic parenchyma after the TACE procedure will make future TACE more difficult. DEP TACE, which targets only the arterial end of the tumor, may result in this scenario, whereas C TACE, where we do ultraselective cannulation and penetration of the lipidol emulsion into the peripheral portal vein radicals along with the tumor vessels, can result in a better tumoricidal effect of the tumor as well as the surrounding liver parenchyma with microsatellites. All the RCTs comparing DEP TACE and C TACE have been have negative conclusions. That means they both are equivalent. Whereas the recent one published in 2020 from Japan, which employs this ultra-selective technique, has shown promise with C TACE in that the objective response rate is far greater than the DEP TACE. Of course, we need the help of cone beam CT as well as ultra-selective catheter position for achieving this. This is an example of ultra-selective microcatheter position with penetration of lipidol into the peripheral portal vein radicals at the end of the procedure, which actually results in a far better objective response rate. Combinations with TKIs as well as like sorafenib and lenvatinib have been studied, and recently they have been proven to offer extended overall survival and recurrence-free survival in this group of patients. And the future of therapy is very exciting because combination of these intra-arterial therapies which have improved vastly in the technique along with immune checkpoint inhibitors are going to be the future of HCC treatment in the near future, and the next 2 years it may change extensively and towards a better outcome. Of course, there are scenarios where TACE will fail or where TACE is unsuitable. We have to give at least 2 chances to the procedure to find out that whether it is a failure or non-response. If the patient doesn't respond more than 50% after 2 sittings, or if the patient has continuing elevation of liver markers or appearance of extrahepatic or macrovascular spread, it is a failure. And if the patient has tumors beyond up to 7 as well as borderline liver function which can be worsened to child B or C, these are the patients who are not suitable for TACE. Coming to TAR, again there is no specific literature in regarding HCC in non-cirrhotic livers. But in the BCLC guidelines, we can see that radioembolization finds a very limited role in early and very early stage where the other treatments are not feasible, and this is largely due to the legacy study. But the real world scenario is different. This was a study published just before the recent BCLC guidelines, which shows that Y90 forms a major treatment paradigm in MDT treatment decisions, and the survival has been better than what the BCLC algorithm provides. So Y90 still finds a role outside the BCLC, of course with the decision of the MDT. And the outcome of TAR depends on, one, the efficacy depends on the dose delivered to the tumor, and the safety depends on the dose delivered to the surrounding normal liver. Parenchymal reserve being good in non-cirrhotic livers has an advantage in this condition. The initial trials were negative comparing with sorafenib, but when we switched over to personalized dosimetry where we give a higher dose to the tumor and a lesser dose to the surrounding normal parenchyma, there was significant difference in the outcomes, and the dosisphere trial was largely positive. And further, the legacy study where we gave a 400 gray dose to the tumor was positive and had a very good complete response rate. In TAR, there are 3 scenarios where we can do a segmentectomy. It is always better. The second scenario is a unilobar disease where we can downstage to resection. It also gives FLR a good hypertrophy. And the third scenario is where we don't have any kind of personalized dosimetry. We have to give a standardized dose to the whole liver. That's a scenario which is a palliative option. So to summarize, liver resection is the way to go in non-cirrhotic patients. However, in this group also, patients who are more than 65 years with tumors less than 2 centimeter, ablation is equivalent to liver resection in survival. In all other patients, resection fares better. And if patient is not resectable, locoregional therapy has to be given. And the choice of LRT up to 3 centimeter in feasible patients, ablation is the way to go. If 3 to 5 centimeter, you combine it with TACE and aim for thermal segmentectomy. CTACE is found to be better than DEPTACE in certain situations. Of course, these are not for large tumors, these are for small tumors, and CTACE has to be given a more significant weightage. And TAR, which can be performed across stages from very early to intermediate stage, even to an advanced stage with macrovascular invasion, has to be tailored to the particular patient, because we need to know whether it's a small tumor which we can do a segmentectomy, or a very large tumor which we need to have a bilobar TAR sessions. So tailoring the treatment to the particular patient and what stage the patient is, with an aim always to achieve cure, is going to be the cornerstone for treatment of HCC in non-cirrhotic livers. Thank you.
Thank you, Dr. Santosh. We'll have questions and answers maybe at the end of the session. Please join us here. Yes. May I invite the next speaker, Dr. Rajesh Rajalingam, who is a senior consultant and clinical lead HPB surgery at Dr. Rela Institute and Medical Center, Chennai. And he'll be speaking on, he'll be presenting a case scenario and how to deal that case and the points carry home message from that case. Dr. Rajesh, please.
Thank you. I would like to thank Professor Sareen sir and Dr. Ashok for giving me this opportunity. I would ask my colleague, Dr. Tushar, to run through the case, and then we'll have the discussion.
Good afternoon, everyone. So I'll be presenting this case. It is from Rela Institute. So we have a 65-year-old male who presented with a history of weight loss for about 10 kgs along with the loss of appetite for the last 2 months and had a history of low-grade fever for the last 2 weeks. He's underlying diabetes and hypertension for more than 10 years. In 2010, he had a coronary event for which he has underwent PTCS stenting. In the family history, the patient's younger brother, he had history of, he died due to the liver disease, but details regarding which were not known. The patient had a BMI of 27, performance status was good. He's non-ecteric with no clinical signs of any chronic liver disease. Per abdominal finding, the abdomen was soft and liver was palpable and there was no free fluid. In the investigations, the patient had serum bilirubin of 2.5 with direct of 1.6, albumin of 3.3. There was LASE, ALPHOS and GGT with transaminases with 87 and 69. INR of 1.2. He had no endoscopic evidence of any varices. Platelets count were 390,000. His virology was negative and the AFP was 1.2 log 3 with MELD score of 13. In the CT, the patient has a very large lesion of about 14 by 10 centimeter involving almost an entire right lobe. There was no macrovascular invasion. The tumor was playing the hilar structure, especially the right portal vein and the biliary system, but the RHV, MHV and LHV were free of tumor. There was mild central IHBRD. The liver was normal with the normal spleen. There was no splenomegaly, no collaterals, there was no ascites. There was no significant lymphadenopathy, also chest was normal, no metastasis. So with this, I'd like to forward to Dr. Rajesh, sir.
Thank you, Disha. So looking first at this case, it looks like a very elderly gentleman with deranged liver function test, even though his performance status was okay. And looking at the imaging, the CT scan showed that it's a very large tumor. So it doesn't look like a very good tumor to have it. But the case has been selected to look into few details. For example, this patient, the clinical details, his age is one thing and he has a lot of comorbidities. But in labs, initial look at it showed that there is a deranged liver function test and his bilirubin is 2.5, which will decide on the surgical management. But there is a finding in the CT scan which helped in understanding the liver function. For example, the mild is IHBRD. So basically the lesion was pushing the biliary confluence and it is causing a dilatation. So that bilirubin of 2.5 is not of direct correlation to his liver function, and his INR was normal with platelets, which is the most important clue here when we decided the treatment options for this patient, which is 3.9 lakhs. And CT scan also showed that there is no evidence of any portal hypertension, clinically significant portal hypertension, or like the spleen size was normal, and there was no evidence. So these are the things which helped us in going forward in evaluating this patient further for curative option. Otherwise, it would have been more of a palliative. So I would like to put it across like the role of MRI and PET scan in this patient going forward in treatment management. Let's say this patient has an option of surgical treatment. So MRI, I would say that a large lesion, especially with a high tendency to have a microvascular invasion, MRI has a tendency to pick up smaller lesions in the remnant liver compared to CT, and that's where we found it to be useful, and PET scan for extrahepatic disease. So the diagnosis in this case is BCLCA. The reason is it's a single tumor, even though it's 14 centimeter in size. It's a single tumor. It's a non-cirrhotic liver based on the imaging and the labs. Preserved liver function, thinking that the liver function, bilirubin is because of obstruction, the good performance status, and the remnant liver volume that has been calculated is 40% on the left side. So the option available, still curative option is available in this patient. Resection, transplantation, combination therapy or ablation. Going for curative option, his age, considering the age and the non-cirrhotic liver, transplantation will come down in this, whereas resection will be the first option which we would think of. The panelists agree to this or any other comments? Okay. Or should I run through and then have the questions later?
I would have thought resection will be the best option.
Yeah.
But in this case, the alpha fetoprotein is 1300. I'll be tempted to see what the PET looks like. I'll be doing a PET scan on him, and just to see whether it is highlighting on PET, also to rule out any extrahepatic disease. And then because of his high AFP, his age and all other factors keeping in mind, I may be actually tempted to do a session of TACE before doing a resection on him.
Yeah, we also agree.
Although the remnant is good, okay? But
yeah, with the high AFP, we always do a TACE as a marker of whether there is an extrahepatic disease. If the fall in the AFP is significant by doing a TACE logaritmal therapy, if there is a significant fall, then we are sure that there is less likely to have an extrahepatic disease. Yeah, we do it as a selection method. So in this patient, as I say, for a surgical fitness, apart from the comorbidities, you run through the lungs, cardiac status, everything. The liver function test is assessed by the MEL score. Here the MEL score is pushed by the bilirubin because of an obstruction, so it is false positive here. Portal hypertension features, apart from imaging, the gold standard is HVPG, whereas here from imaging itself and the platelet count itself will give us a clue. And surgical option, this is amenable for resection of the remnant of 40%. So we went ahead and then we got the surgical fitness, and then because of 40%, he didn't have any preoperative optimization of the liver volume. Introp, this is a picture. First look at the liver, it looks like a cirrhotic liver, but the liver is soft, and it's more of an exophytic 14 centimeter lesion. And the pressure, I would like to say is, the pressure was 8 centimeter of water at the, without clamping the right portal vein, and it is 10 with clamping. That says that it is a good remnant liver that is there. And then we went ahead and then did the resection, and then patient did well. In fact, this is a post-op LFTs. The highest peak bilirubin was around 1.8, and there was 700 ml ascites on day 2, day 3. After that, it settled down. So he went through without any much of problem. So the thing is, in this case, it's understanding how you interpret your deranged liver function test with imaging findings, and giving an option of curative rather than straight away going for palliation is what I want to stress. And moreover, for these patients, adjuvant therapy is important because of the high incidence of microvascular inflammation in these large tumors. Thank you.
Thank you, Dr. Rajesh. Please join us. Any comment from the moderators on these 3 presentations?
So I just want to ask a question with Dr. Pamecha. Nice talk. So my question to you that with the background of cirrhosis, within the criteria, transplant is the best option. So where does transplant lie in the setting of non-cirrhotic liver with large tumors?
I wouldn't be transplanting in a non-cirrhotic liver, unless there is some, I don't see any reason why I should be transplanting at a non-cirrhotic HCC. I don't see any reason why one should be transplanting a non-cirrhotic HCC, unless, even if there is a remnant problem, that remnant volume, which is not going to, because in large HCC, remnant volume is not a problem actually, because most of that is occupied by the tumor, and then you can do augmentation by portal vein embolization and combining with TACE. So, I don't see a upfront indication to do a transplant in a large non-cirrhotic HCC. Okay, in a recurrence disease, maybe patient who had recurrence many years after and multifocal recurrence, then there may be a reason to do a transplant.
Suppose patient is having background chronic hepatitis B.
That doesn't give you an indication for transplant. So hepatitis B, you should treat the virus first before actually even resecting them. So you should start antiviral. I'll start levodopa as well before even doing resection. And once I got the viral load down, and that will also, levodopa will also take care of the tumor at that time. And maybe if required, I will do a TACE and then resect them.
What about recurrence?
So hepatitis B, if the viral load is low.
Recurrence of tumor.
If the viral load is low before you do the resection, then the chances of recurrence are low. If the viral load is high, and if you have ongoing transaminitis after resection, then the recurrence rates are high. So there is clear data on that. Ongoing transaminitis, that is that the activity is going on, hepatitis B activity is going on, then the recurrence rate. So you need to control the virus.
So others, in a patient, in a non-cirrhotic patient, upfront resection is the one. But resection itself can act as a selection criteria. For example, you do the resection and then the biopsy shows multiple high-grade dysplasias. You closely follow up the patient, and if they have very poor pathological findings, then actually you can upfront, you can give 6 months time, and then there are literature now coming up where transplantation, salivary transplantation has been given an option if they have a bad tumor.
Okay. We'll go to the last talk of the session, which is a liver quiz and carry home message by Dr. S.P. Singh. Dr. S.P. Singh, please.
Thank you, sir. So I'll be speaking on non-cirrhotic HCC protocol, what we do, and a few quizzes. So a patient with primary HCC without metastasis, we will rule out cirrhosis by means of cross-sectional imaging in the form of CT scan, MRI, PET CT. Depending on AFP, if it is more than 500, we will rather do PET CT. Fibroscan, it is less than 6, then it is okay. No viruses. HCPG less than 5 is okay. ICG less than 10 is okay. Retention test at 15 minutes. And spleen stiffness less than 21 rules out portal hypertension. Less than 32 rules out any varices also. So if it is a patient of cirrhosis, then we will follow the inasal BCLC staging. And if it is a non-cirrhotic, simultaneously we will assess for viral hepatitis. Some hepatitis B can cause non-cirrhotic HCC, NASH, germline mutation, or inherited disease. If there is no fibrosis, LSM is less than 6, we estimate the FLR. If it is more than 30%, we will consider resection and closely follow up. As there are chances of recurrences very high after resection, we might do some adjuvant therapy after the follow-up. If the FLR is less than 30%, we might do some volume augmentation in the form of portal vein, ALPS, hepatic vein embolization with TACE. And if adequate FLR is achieved, then we will go for the resection. And if it is not achieved, then we might consider loco-regional therapy, especially in cases of VP3 and VP4. VP1 and VP2 can be taken as a non-cirrhotic and can be followed. So in case of borderline fibrosis with the LSM 7 to 15, we might consider for the biopsy from the native liver to rule out any advanced fibrosis. If there is no advanced fibrosis, then we estimate FLR and go for the resection if it is more than 30%. So I have few quizzes. Answers depends on how attentive you were. So quiz 1, what is the incidence of non-cirrhotic HCC amongst all HCC patients? Option 1 would be less than 5%, 2 would be 5 to 15%, 15 to 20%, or 30 to 35%. Okay, so 15 to 20% is the right answer, and most of them has gone about it, but some are 5 to 15%. So answer is 15 to 20%. Second question is true regarding radiological appearance of HCC in non-cirrhotic patients. They are small, multiple lesions. They are usually large, singular lesions. They are non-enhancing lesion in arterial face, or they are large lesion with capsular retraction and IHBR. So that's 100%. They are usually large singular lesions. So third quiz is what is the risk of recurrence after resection in non-cirrhotic HCC at 5 years? Next. So risk of recurrence after resection in non-cirrhotic HCC at 5 years, 15 to 20%, 30 to 35%, 40 to 45%, or 60 to 65%. So most of the answers are very optimistic, but it is around 40%. That's all. Thank you.
Okay, with this, we end this session and move to the next session. Thank you so much, all the speakers and my co-chairpersons and moderators. Thank you.
I thank our esteemed chairpersons, moderators, and speakers of the session and invite them for a group photograph. The next session is gallbladder and other cancers. And the chairpersons for this session are Dr. S.K. Sinha, Professor, Department of Gastroenterology and Hepatology, PGIMER, Chandigarh. Dr. Piyush Ranjan, Senior Consultant, Department of Gastroenterology, Sri Gangaram Hospital, New Delhi. Dr. Nikhil Himthani, Consultant Oncologist, ILBS. And the moderators for the session are Dr. Abhideep Chaudhary, HOD HPB Surgery and Liver Transplantation, BLK M.I.C.E Super Speciality Hospital, New Delhi. Dr. Murali Apukuttan, Assistant Professor, Department of GI Surgery, Bharat Hospital, Kottayam. And Dr. Vikash Prakash, Department of Hepatology and Gastroenterology, AMRI Hospital, Kolkata. I invite them on the stage, please. The chairpersons may please introduce the first speaker. Thank you.
Good afternoon, everybody. So for this session on gallbladder and other cancers, the first speaker is going to be Dr. Anil Agarwal, who is head of the Department of GI Surgery, GB Pant Hospital, New Delhi.
Good afternoon. Oh, the time has been reduced, is it? Okay. Anyway. So my brief is to talk about the surgical options, and I think in view of the limited time and because I can see that there are talk on neoadjuvant and also Dr. G.V. Rao's talk on improving survival. So this is as per AJCC staging. So what is advanced gallbladder cancer? Now, is it T3, T4 as has been usually talked about? Like this was the initial papers, Miyazaki et al., then they talked about that in which they took T3, T4 and talked about adjacent viscera involvement. And they said that something needing more aggressive resection would be an advanced gallbladder cancer. Or N1, N2, because now we know that lymph nodal positivity also will be classified into that advanced stage. This was a nice paper from Mahesh Goyal group from Tata, and in which they were trying to look at that can be defined borderline resectable and can we talk about role of neoadjuvant treatment. And you can see it talks about T3, T4 and node. Vascular tumors will again come in T4, so that is included in that. And so if you look at T3 and beyond, it all includes anything which is T3 or T4 or T3 or beyond, or it is lymph node positive, will constitute as an advanced. However, if you look at the surgical literature, they talk about that when you need more aggressive resection. So I think my brief also today is to talk about that which are these patients in advanced gallbladder cancer in which you need more major resection. These are some of the series Yamamoto et al. And Shimada in which they talked about those patients which will need more extensive right hepatectomy. So I think from the surgical standpoint, let me talk about mainly because incidental gallbladder cancer or gallbladder cancer limited to gallbladder would be most of them may be limited to the gallbladder and will need a standard radical cholecystectomy. However, for loco-regional, and in the end, I will talk about that now that there is more scope of surgical the metastatic gallbladder cancer. So I think for early gallbladder cancer, it will be a straightforward standard radical cholecystectomy, which includes segment 4B5 liver resection and lymphadenectomy. And of course, there is a role of staging laparoscopy. This is our paper in which we talked about that in advanced gallbladder cancer, the likelihood is more of finding these metastases 25.2% versus 10.7 in early tumors. And you can also do an intra-aortocaval lymph node sampling if you have not done the EUS FNA before. And this is meta-analysis in which they talk about that there is a role of laparoscopy. And this is just to show that a straightforward would need a liver resection and lymphadenectomy, and this is what it will look like after resection. And bile duct excision may be required. I mean, some people advocate that beyond T2 tumor, which they will call an advanced tumor, you should do a bile duct excision, but we, like many other centers, restrict it to some of the tumors in which either there's a direct involvement or, as you can see in the picture, one with the choledochal cyst, and this is with the tumor embolus. So, talking about aggressive resection or advanced gallbladder cancer would be needing adjacent viscera involvement. So, if it is liver infiltration, wedge or segment 4B, you can choose whatever you want if it is an R0 resection. But some of these patients may need extended resection based on whether there is an extensive tumor. This is just to try to show the basis of segment 4B5 and how you do it. But I'll skip that because this is more a surgical technique related. But when there is, like in this body tumor, when there was more extensive involvement, you'll need an extended right hepatectomy. Or when there is a gallbladder neck tumor and bile duct involvement is there, like in this case. But in these cases, when you do an extended right hepatectomy, you can save segment 4A, which will give that additional liver tissue so that risk of liver failure will be less. And if you found that FLR is not enough, then you can resort to portal vein embolization or ALPS. Now, talking about adjacent viscera involvement, that is a duodenal-pancreatic region or colonic. And in fact, earlier on, literature talked about doing an HPD in a lot of these cases. However, it is a more morbid procedure, and we tried to look at our data, and we started doing a limited resection, and we realized that probably a lot of these patients you can do with a limited gastroduodenal resection, like as you can see in this picture, in the top picture, when there's only a small knuckle, so you can do a sleeve resection. When there's more extensive involvement, you can do a distal gastrectomy, and what we earlier called as distal gastrectomy D1 resection, but I think it is more of because you can include part of D2 also, so distal gastrectomy and proximal duodenectomy. And this is a larger area of involvement. You can see that it is being stapled. And if there is a narrowing, then you can do a gastrojejunectomy. This is another example of large area involvement in which you go ahead and do a distal gastrectomy, proximal duodenectomy. And so this is our approach, that we would do a small area of contact duodenal sleeve resection, otherwise distal gastrectomy and proximal duodenectomy. And we published this paper in 2007 in which we talked about that it leads to meaningful survival. And same as with colonic involvement, you can have like in this case, you can see that there's a transmural involvement, but otherwise, a lot of times it's only the serosa which is involved, and you can again do a colonic sleeve or a right hemicolectomy. Some of those cases, like in this Professor Miyazaki's series, in which there may be both duodenum and colonic involvement, as in this case, and in these you see the bile duct is all right, and so you can go ahead and resect the duodenum as well as the colon, and this is what remains. And sometimes, like in this patient of ours, there was a diaphragm involvement, and so we had to do, in addition to colon duodenal involvement, diaphragmatic involvement. Or this patient presented with cholecystocutaneous fistula, so you have to resect entire thing as a cone, and you can see that part of the ribs also resected, skin, and all these can also be which leads to reasonable survival. So what about pancreatic involvement? And in these pancreatic involvement, earlier on they were talking about HPD. However, this very nice paper from Satoshi Kondo group talked about that if you do because it is usually the upper outer part of the pancreas which is involved, so you can still do a limited resection, and so that HPD is restricted to more extensive involvement of the duodenopancreatic area. And now the same thing can be done by laparoscopic approach, like this Professor Han had showed in his paper. This is just talking about same thing you can do with the laparoscopic approach. These are some of the papers in the literature which talked about excising either the adjacent viscera or the bile duct. This is our experience in which you can see the duodenal or the colonic involvement, choledochal cyst, and this is the bile duct with the neck tumor. And this is talking about, this is a paper we published recently, some time ago, with 11 cases in which the adjacent viscera were resected. And it was nice to see one of our earlier colleagues, Kalai Rasan, has published hepatopancreatic duodenectomy, also laparoscopic. So with biliary obstruction, now earlier on there was nihilism for biliary obstruction, then we published this paper that it is not sine qua non of inoperability, and then Rajimbo also talked about the same thing, and the final nail was hit by Nishio-Nagino group, in which they talked about that it leads to meaningful long-term survival. Of course, it is a high risk for liver failure, so you have to resort to preoperative drainage and sometimes preoperative portal vein embolization. But obstruction at the level of common hepatic duct, that is type 1, most of them you can do a limited resection segment 4B5, as you can see in this picture, and you can see that this is in the right duct and this is the left duct, and you can get a reasonable margin by parenchyma preserving resection. And the same thing can be done laparoscopic also. As you can see, this is a case which we did last week, in fact 4 days ago, in which you can see that there is a stump, there's a hilum there, and you can see that above this is, I'm holding with the left hand the tumor, and there's significant amount of bile duct there, and cutting it close to the hilum, and you can get a reasonable margin. Just trying to show the same, this is a case prior to this, second last case, I think. Oops, sorry. Oops, maybe if time is not there, just trying to show that bile duct is being looped there. And this, you can see that this is where the tumor is, this is above the tumor. You can make the plane, divide the bile duct. And do the anastomosis. Right, so I think in the interest of time, confluence when it is not formed, this was our longest survivor, which was with extended right hepatectomy, but you can do a limited, as I said, you can preserve segment 4A, and even when the hilum is involved, you can do a segment 4B5 resection. This is another patient, again done laparoscopic, in which there are multiple ducts to anastomose, but you can achieve the same thing by laparoscopic approach also. You can see the anastomosis being done with multiple ducts, so it will be taking more time and more patience is required. Now, so a lot of literature supporting that. This is our paper, and so you can do this is a paper we have sent for IHPBA, in which 8 patients we have done by laparoscopic approach. Vascular involvement, you can do a right hepatic artery reconstruction, or even with right hepatic artery involvement, we have gone ahead for resecting segment 4B5, and when the portal vein is involved, you can do again saving segment 4A. When there's a main portal vein involvement, like in this case, you can do a repair, or you can do a main to the left portal vein anastomosis. And when both are involved, the portal vein and hepatic artery, we would not go ahead, and till now we haven't done that, but some centers in Japan would still go ahead and do a resection. This is our experience of which we published earlier, 2006 to 12, and in which single or multiple organ resection was done, and the resectability rate in this was 57.5% because we resected 2 or more organs. And this is just the data. I'll just skip through that because I know the time is up. And we showed that it led to a reasonable survival when adjacent viscera was resected, though of course bile duct was lesser survival as compared to duodenum and colon. And this is the same paper that I alluded to, and this is from the literature. I'll just skip that, I think. Just coming in the last 1 minute, for the metastatic gallbladder cancer, because now in those also you can do an extensive resection. We can divide that into distant nodes, intra-aortic cable lymph node or celiac lymph node. There can be selected patients, you can still do a resection, or intrahepatic metastasis, which is in that segment 4B5, you can still go ahead for resection. Port site scar recurrence leads to long-term survival, and peritoneal omental spread, which is adjacent to the gallbladder cancer, you can resect. And what leaves behind is when there is a totally disseminated disease. And this is again a nice paper from Tata Group which talked about that oligometastatic disease, you can still go ahead for resection. And this is one of our patients in which we did a scar site metastasis resection, which survived 2 years plus. And one lady which after open cholecystectomy, gallbladder cancer, survived 5 years. And this is another patient in which there was a axillary lymph node which was there, and in this resection was done. So, okay, thank you very much. I think I'm exceeding time. Thank you. I thought I had 12 or 13 minutes, but okay, thank you.
Thank you, sir. Sir, you may join us here. We'll have questions if time permits at the end of the session, or you can join in the case discussion which follows.
So next talk is by Dr. Dipanjan Panda. He is a senior consultant in Department of Medical Oncology, Apollo Hospital, Delhi. The talk is on advanced carcinoma, gallbladder, chemotherapy or chemoimmunotherapy, which to choose.
Thank you. I thank organizers for giving me this opportunity. So this topic was given to me by that management of advanced gallbladder cancer, chemo or immunotherapy. So without, I mean, the gallbladder cancer is the commonest of the biliary tract cancers, and as you know, India stands for a high incidence zone along with Chile and Ecuador in South America and Central European countries like Poland. And gallstone seems to be the most common cause. 90% of the gallbladder cancer and biliary tract cancers are unresectable and advanced stage, and patient treated with current standard of care, gemcitabine, cisplatin, and median overall survival with this man, that is less than 1 year, and a 5-year overall survival rate of less than 10%. And if you see the trends, the incidence of biliary tract cancer, including GBC, is male and female in going over the years. As you know, Delhi, along with Assam, has some of the highest incidence area for gallbladder cancer, especially in female. With publication of this particular paper in New England Journal of Medicine about 10 years back, the gemcitabine and cisplatin became the standard of care. It did show a clinically meaningful, statistically significant improvement in overall survival as well as progression-free survival of 11 months and about 8 months. And this paper has shown that out of 410, about 150 patients was gallbladder cancer, so we can take that this became a standard of care for gallbladder cancer also. Now, since cisplatin is not exactly chocolate and it has got a number of side effects, especially in a borderline cardiac and renal function, so people have tried other type of platinum like oxaliplatin. This is a paper from Aldini Institute by my teacher, Professor Atul Sharma. They did show that GMOX, modified GMOX, can be equivalent to gemcitabine cisplatin. This is a paper from TMH, Anant Ramaswamy et al., and they have also did a match pair analysis and found that both gemcis and GMOX can be used as an initial regimen. The cisplatin can have a lower cost, lower incidence of peripheral neuropathy and hepatotoxicity. However, oxaliplatin can be superior in patients with borderline renal and cardiac function. We did, when I was in ILBS about a decade back, we did some observational study and did show, we thought in a better institute we can improve the overall survival, but that was not to happen. That shows basically with doublet chemotherapy or bleached plateau. There will be people, other drug like modified FOLFIRINOX has been tried by Professor Sharma's group with PRODIGE. They showed excellent response in pancreatic cancer. And we have seen that it is feasible, but the toxicity quite sometimes, and it's not yet standard of care. The paper which we really put our heart on was this paper by Milind Javle and Rachna Shroff et al. In this gemcitabine, cisplatin, nab-paclitaxel triplet. They show a superior response of 45% and a disease control rate of 84% in the phase 2 trial. However, to our dismay, in the phase 3 SWOG 1815 did not reach a statistically significant improvement. But voila, this is, that's why I'm trying to tell you that gallbladder cancer is not like other biliary tract cancer, and this we will come again and again, that this only 16% of this particular patient group was gallbladder cancer. And if you look at the median overall survival of gallbladder cancer, it is 17 months versus an overall MOS of 14 months, whereas the rest of the response, not only the OS, the PFS, and overall response of gallbladder cancer subgroup were much better than the overall BTC group. This is one of our students, Chandrani Khatri. She did it part of a DNB thesis, and it is under publication. It also showed that overall response rate of gemcis, nab-paclitaxel. This is only 60 patients, but that actually indicates that most probably we have not seen the end of triplet therapy. For a country like us, where the immuno-oncology is quite expensive, I still believe in a gallbladder cancer subset triplet therapy has some role. So this is the overall chemotherapy in BTC. The gemcis remain the standard of care till from the ABC0 trial data. Gemcis, nab-paclitaxel did show superiority in phase 2, but phase 3 did not show statistical significance. We will discuss about addition of immunotherapy in the TOPAZ-1 trial. In second line, FOLFOX, irinotecan, and 5FU, and has some options, but most of the second line options have 5 to 15% response. I believe after pancreatic cancer, lung cancer, biliary tract cancer is a subgroup where the maximum work on molecular biology is going on. But if you look at the subtype, you can very clearly see that gallbladder cancer is a distinct entity. If you look at the mutation, the FGFR mutation or the IDH1 mutation of which extrahepatic cholangiocarcinoma we have drug, that is either 0% or 2% in gallbladder cancer, where the common mutation which we are seeing is ERBB2 expression or CDKN2AB loss or ARID1A alteration, none of which are seen commonly in other subtype. So while we can say that biliary tract cancer has gone beyond conventional therapy with an IDH1 inhibitors of ivosidenib or FGFR2 rearrangement inhibitor futartinib or imigratinib, or for anti-CTLA4 tremelimumab or durvalumab pembro is working on, for gallbladder cancers, it may not be so. So I again reiterate, all biliary tract cancer are not the same, and all mutations are not the same. If you look at this paper from Giraldo et al., which was published last year, that mutations have both prognostic and predictive value. Both IDH and FGFR mutations are uncommon in GBC. ERBB2 remains the most important actionable mutation, and STK11 mutation has shown a lower response to immune checkpoint inhibitors, which is one of the most important mutation as been seen. So while looking at the TOPAZ-1 data, we have to remember this. So about HER2/neu blockade, so there has been a paper called My Pathway Group, which has shown that trastuzumab plus pertuzumab can show a good overall response of 23% with a PFS of 4 months and overall of 10.9 months. There is also a multi-center phase 3 trial of trastuzumab deruxtecan, which I believe once comes to this country will change the way we treat HER2 positive diseases, both not only breast but as well as GI cancer and hepatobiliary cancer. So it also did show, I have to skip this, so promising activity with better response and efficacy, both not only in HER2 positive but also a subset called HER2 low disease, which is FISH IHC2. There is also a promising drug called zanidatamab, which is a bispecific HER2 antibody, and it's showing a response rate of 41%. But the limitation of target therapy is that there is a limited population and several other targeted agents are not sufficiently evaluated. Coming to immunotherapy, the nivolumab was first tried within second-line options, and it did show some promising activity, especially in PD-L1 activity. Pembrolizumab also been tried with some response, but the trial which changed the way we treat gallbladder cancer was this TOPAZ-1, which is a phase 3 randomized trial of gemcitabine plus cisplatin plus durvalumab versus gemcitabine plus cisplatin with placebo in first-line unresectable biliary tract cancers. 685 patient, 1:1 randomization of gem-cis durvalumab versus gem-cis. Primary endpoint were overall survival. Key secondary endpoint was PFS, response, duration of response, safety biomarkers. Needless to say, it did show there was a statistically significant improvement of 12.8 months versus 11.5 months. But more important is that continuous divergence of these two curves. It means in simple Hindi, jo jita wahi second, people who does show good response continue to have a better survival. So the HR continues on improving from 6 months to 24 months. There is a continuous separation of curve. It did show a response rate across subgroup. However, the gallbladder cancer group was slightly inferior than the rest of it. The secondary endpoint was PFS, which was also statistically significant. But this is the slide I would like you all to kindly have a look. Patients who have the ERBB2 amplification alteration or patients who have got a ARID1A wild type are doing inferior to the durvalumab combination compared to the BTC. And please remember my last slide that ARID1A and ERBB2 amplification are higher in gallbladder cancer. We also have seen pembrolizumab with gem-cis. It did show an overall survival benefit. However, there was not much differences on PFS. So in 2023, we have come a long way. Post TOPAZ-1, durvalumab gem-cis has become the standard of care across biliary tract cancer, including gallbladder cancers. We have the other recommendation, which has become the other reason, like gem-cis or FOLFOX. We also have a whole range of targeted therapy which can be used in different circumstances, like NTRK fusion. We can use entrectinib or larotrectinib. For MSI high, we can use immunotherapy. For tumor mutation burden high, you can use doublet of immunotherapy. However, please remember that there is something called tissue agnostic disease, that in spite of having different tissues with same mutations, we can use these drugs, but they are fewer in numbers. There are some ongoing major clinical trials like devimistat, ipilimumab nivo, tucatinib with trastuzumab in HER2 positive, and bintrafusp alpha with gem-cis, and we will bet the future is quite interesting. However, However, when Ashok gave me this title, I thought this is not a right title. So the important question, I was supposed to ask chemo or immunotherapy. So if you remember, one of American president post 9/11 says, you are either with us or against us. I think it is good for politicians to take this extreme pole position, not for scientists, especially for politicians who forget to open up their eyepiece lid before looking through their looking glass. So the important question, chemo or immunotherapy? Chemotherapy has been standard of care for long. It's relatively inexpensive. It works across subgroup. It has been proven to improve survival in large randomized controlled trial. We have good amount of experience in handling chemotherapy. SWOG trial did show that triplet can show good response, especially in gallbladder cancer. However, the overall response is modest for GBC, and research for new therapy is actively going on. Targeted therapy is now approved in second line, but more evidence and ongoing phase 3 trial is required. The problem is gallbladder cancer is different disease than rest of BTCs. And targets in gallbladder cancer are few, and except ERBB2, no actionable mutation has been found till date. Unlike cholangiocarcinoma, IDH and FGFR are not seen. Patient having ERBB2 mutation amplification has also overall poor prognosis. Post-Topaz and GEM-CIS in durvalumab have been promoted, news, standard of care. Subset analysis, I'll be taking 30 seconds. Last slide, this is my last slide. Subset analysis from Topaz shows that response to GBC are relatively modest, especially ARIDH, ERBB2 mutated subset. There is no one size fit all in management of GBC. While chemoimmunotherapy has shown superior response compared to present standard of care, the improvement in GBC subset is modest and not uniform across all subgroups, especially with ERBB2, STK11 and SMAD4 mutated disease. Cost of immune checkpoint inhibitor is prohibitive and beyond means of most individuals. So individualization according to clinico-pathological and molecular presentation, socioeconomic background, and logistics needs to be considered before choosing the treatment options. And last but not the least, my request, a large RCT exclusively comparing gallbladder cancer and not compiling them or combining them with BTC is the need of hour. All biliary tract cancer are not same, definitely not gallbladder cancer. Thank you.
We can have one or two questions.
Yeah, I think I completed in 12 minutes, 20 seconds.
I would like to ask one question. So what is your first line preferred treatment, the triplet regimen, GEM-CIS, nab-pacli for gallbladder cancer or combination of chemoimmunotherapy?
Okay, so that's a very good question. This is a practical question I think any oncologist will ask. So once nowadays I have completely shifted to doing an NGS and PDL1. I do the PDL1 by DACO to bring uniformity. And to my experience, about 10 to 15% of our patients are HER2 positive. So for HER2 positive patients, no immunotherapy, we give them GEM-CIS with trastuzumab, and our response has been good. For the rest of the patients, since NGS takes a time, the turnaround time is about 3 weeks to 4 weeks. We start them on gemcitabine and cisplatin. If this is a new practice, so if the NGS has shown some of those mutations which I believe are not good, like STK11 or SMAD4, then I continue with them either doublet, and if they are fit enough, I can take them to triplets. Otherwise, if the patient can afford, we put them on durvalumab. But you can understand the cost of durvalumab, you know better than many of us, it's pretty big, and we don't want patients to sell their houses to get a 3 months. I mean, these decisions, it's very easy to talk about durvalumab or other immune checkpoint inhibitors sitting on this podium in this 5-star hotel, but when in real life, you have to take what exactly the amount of benefit. Now people say life has no value, no price, you cannot put a price tag on life, but what extent are we getting and what percentage, and when the patient leaves, he leaves some kids to feed. So that decision only a clinician has to take, and I think an open discussion with the patient is the need. And as I am again and again repeatedly saying, do not confuse gallbladder cancer with other biliary tract cancer. It is maybe anatomical proximity is there, but it is a completely different subset from an extrahepatic cholangiocarcinoma. It has a poorer disease, it's a different mutations, and most probably it requires, most of the problem with the Europeans, they don't have enough gallbladder cancer. So the large randomized gallbladder cancer trial on these needs to happen here and we hepatologists, oncologists needs to come together to push that agenda to the pharma companies, even investigator-initiated trials.
Dr. Dipanjan, if I may interrupt you, in say in an adjuvant setting, what would you recommend in an adjuvant setting? You talked in the terms of unresectable cancers. In an adjuvant setting, what would you recommend? And what mutations should we think of getting?
Sir, in adjuvant, unresectable, there is no adjuvant setting, sir.
No, in adjuvant setting.
Sir, in adjuvant setting, I generally use the only published paper shows single agent capecitabine. But if you have read the BILCAP study, that paper was not really powered. So in my practice, I can say I use the GEMCAP, which is, we have a data from other biliary tract cancer and pancreatic cancer like SPAC4, but people have used GEMCIS, GEMCAP, and even single agent capecitabine. There is no standard of care. As far as adjuvant radiation is concerned, there is also some controversy. So that is an unresolved question.
I would like to ask one more question. If a patient receives GEM-OX in the first line regimen, if the patient progresses on it, then what is regimen you use in the second line setting? Because commonly we switch to FOLFOX.
Yeah, that's a difficult situation. What happens? I mean, you can use an irinotecan-based regimen, but that is not very effective. You can sometimes use single-agent capecitabine. And in these cases, I usually, if the patient hasn't undergone a NGS, I do send. And even I have used immunotherapy along with chemotherapy in the second line. I discussed sometime with Anant also. So in patient, we use even FOLFIR with durvalumab in a patient. But obviously, that area is still unexplored. And we have a lot of explored to do. But please look for HER2 mutation. You will be surprised to know Indian patient has a good amount of HER2 mutation. It's more than 10% any day.
Thank you, Dr. Panda. With that, we move on to the next talk. I invite Dr. Sonal Asthana, who is clinical lead HPB and multi-organ transplant surgeon at Aster Group of Hospitals. He is going to talk on neuroendocrine tumor, the current concepts in managing the liver metastasis.
Thank you so much to Professor Sareen and Dr. Ashok for their very kind invitation. I shall be talking about liver resection or transplantation neuroendocrine liver metastasis. As expected, I'm a surgeon. A lot of my talk is going to be on the surgical aspects of management. The first thing to understand is that in NET liver metastasis, it's very, very difficult to define a standard, or what is considered to be atypical in most of the tumors is actually what you commonly encounter in most of these patients. So when we look at the basics, we know that a large proportion of NETs arise from the small intestine, some from the colon, the rectum and the appendix to a smaller degree. The rectum typically does not metastasize to the liver, so most of the metastases that we encounter in the liver come from the small intestine or the pancreas. There are slight differences in nomenclature. When we talk about NET, when we talk about grade 1 NET, it's defined by the mitotic epitope index and the Ki-67 index. The second one seems to be more relevant. And grade 3 or high grade, what is called neuroendocrine carcinoma, is exclusively defined as a Ki-67 index of greater than 20%. What about the distribution of neuroendocrine metastasis? So this is again graded into 3 types. If you have a single metastasis of any size, that comes under type 1. The type 2 is an isolated large bulk with smaller satellite lesions. And the type 3 is disseminated with both lobes of the liver involved. Again, it's important to emphasize here that there are always more metastases than you think that there are. So if you have something that's a type 1 on imaging, often we find that when these patients proceed to an explant or to a resection, the number of lesions that you find, the number of satellite lesions are actually substantially higher. So this actually is my summary slide. I just want to make this point before we move on. When we talk about the evidence of benefit of surgery for NET metastasis, again, you have the obvious challenges of an uncommon problem, which has prolonged survival and a slow-growing natural history. But here it's also important to understand that the survival for liver resection is 50%. The survival for liver transplant is 60%. Okay? And essentially, what seems to benefit is an R0 or R1 survival resection. But even patients who do not have a complete resection don't then do too badly when you actually look at their long-term outcomes. So what factors actually impact the long-term or prognosis of patients who have had a resection? So when we look at the multivariate patient and tumor biochemical factors, the age is important, the small bowel site is important, whether they've had a successful liver resection is also important, the degree of differentiation as one would expect. Alkaline phosphatase is probably a surrogate for tumor load in this situation, and it turns out to be important. Again, liver resection, a successful liver resection seems to do very well as compared to observation alone. But again, other ablative methods such as radiofrequency ablation or chemoablation also improve the survival. But of course, as you can see here, a successful liver resection is achieved with, you can achieve a survival of more than 60% over a 10-year period. What does the extent of the liver metastasis do? Obviously, if you have bulky disease that you can completely resect, that's encountered with that has the best survival. But even patients for whom you can do partial reduction or cytoreduction do have some benefit in survival. Again, who benefits the most from resection? If you're able to do an R0 or R1 resection in a hormonally functional tumor, that has the best outcomes, as you can see from this larger study. These are all very, very large studies of historical data of 350 patients. And this is quite striking because we do not get this kind of data coming out of India, actually. Okay. The median survival, as you can see in this study, is 125 months. And again, there's quite a big difference. If you have an R2 non-functional tumor, your response is actually the least. Again, when we look at multivariate analysis, the obvious culprits stand out, right? A non-functioning tumor, synchronous disease, the site of tumor, etc. But what is notable in its absence is an R2 resection. So when we talk about, say, other oncology surgeries, if you have an R2 resection, that's associated with poor survival, but not so in the case of NET. And again, the degree of debulking or degree of cytoreduction that one can do seems to have a big impact. So if one is able to achieve a 70% cytoreduction, that seems to be optimal, and people who do have a more than 90% survival cytoreduction do better. So even cytoreduction up to 70% of tumor volume has a benefit, even if it's an R2 resection. So again, when we look at patients who are sort of type 3 lesions, who have bilobar disease, extensive bulky disease, even these patients can be effectively cytoreduced. And even in these patients, if you're able to remove more than 90% of the disease, you can get a really good long-term survival of almost 60% at a 15 to 20-year duration. Now, what's the role of neoadjuvant therapy in liver metastasis? Again, this study came from Tata Memorial Hospital, published 2 years ago, where a group with and without liver metastasis, potentially resectable liver metastasis, were treated with PRRT. Now, the challenge is, of course, you had the groups that were potentially resectable to start with, and they both came up with very, very impressive 2-year survivals and a combined overall survival of more than 90%. So the conclusion of the study here was that PRRT is a safer treatment modality. It reduces the morbidity and the mortality. However, most importantly, neoadjuvant therapy in a resectable liver metastasis doesn't improve the PFS or the overall survival. So if there's a resectable liver metastasis where a cytoreduction is possible to more than 90%, then the current recommendation seems to be to do that. Again, with Sunitam, I'm just going to go through this very fast. The surgical strategies right now for NETLM. So if you have type 1 disease, limited disease, single lobe, you can do a standard resection with a resection of the primary. If there's type 2, that is a bulky disease with satellite lesions, you can plan for a 2-stage resection. The idea is to remove at least 90% of the disease. You can do multimodal debulking therapy, or you can aim for downstaging if possible. The evidence for downstaging is weak. And type 3, which is extensive bilobar disease, systemic therapy seems to be the way to go. Follow-up, of course, you follow up with imaging, or you can look at long-acting octreotide, at least in the cases of functional tumors. What are the contraindications for liver resection? patient factors, somebody is unable to undergo surgery, liver factors, when a large volume of the liver is associated or involved in tumor, and when you cannot achieve an optimal cytoreduction of more than 70%. Grade 3 tumors are probably relative contraindications. And when we look at, say, now liver transplantation for anemia, again, the amount of survival described is quite different. Right, from 36% at 5 years to 87% at 5 years. And there again seems to be a sweet spot. This was described by the Milan group initially, when they actually identified a group which was likely to benefit. So this was a group with low-grade tumors, G1 or G2 tumors, a primary site that was drained by the portal system, less than 50% of the liver volume, and where you did not have any extrahepatic disease among patients less than 60 years of age. This was subsequently incorporated to UNOS guidelines, and NET liver metastases currently are eligible for MELD exception points if they meet all these criteria. So these are the criteria where you're likely to have the most benefit or an excellent 10-year survival. Again, anything with a high grade, anything that does not meet these metastases, these requirements, is unlikely to have a survival benefit. Again, if we actually carefully analyze these patients, use a carefully selected group of patients, you can achieve a long-term survival which actually mirrors that of transplantation for hepatocellular carcinoma. There is a difference between carcinoid and non-carcinoid NETs, and there's also a difference between patients who wait longer for a transplant as compared to patients who are transplanted within 67 days. Is there a long-term benefit? Short answer is yes. The adjusted transplant survival benefit, again, this comes from a large study, is 6.82 months, okay, at 5 and 38 months at 5 and 10 years. So the maximum benefit comes in survival beyond 5 years, which is what we would expect with a slow-growing tumor. Slow-growing tumors may not kill people within the first 5 years, but the maximum drop-off may be between 5 to 10 years. And that is where transplantation scores over other forms of therapy. Again, the difference here, the tumor biology is basically the primary determinant. If you look at this graph here, this is also shown in the graphs here, the grade of the tumor that was transplanted, I mean, when you compare that to liver resection and liver transplantation, is actually the primary determinant of whether people do well or do poorly. So who can have a transplant in NET-LT? Grade 1 or grade 2 NET, no extrahepatic disease that is symptomatic, functional tumors, and some patients who have liver dysfunction or failure. I must say that the last liver dysfunction and failure is relatively uncommon. Portal hypertension is a lot more common. If you have a high-grade tumor with an unresectable primary, these are probably bad patients to transplant. Patients with persistent extrahepatic disease will not benefit from transplantation. Also important to understand is even if patients recur after a liver transplant, that's not the end of the world. There are patients with single and multiple sites. The 5-year and 10-year survival after recurrence are quite substantial, 76% and 45%. And it also makes a difference about when the recurrence occurred. So if recurrence occurs after 24 months, that's an indicator of more favorable biology, and these patients can do well for long periods of time. If patients have an absent primary, they should be evaluated fully, but otherwise should deal with the liver metastasis on its own merit because primary hepatic carcinoids, although rare, are not unheard of. Broadly speaking, if we look at NENs, we should look at the grade of tumor. If there are liver metastases, you can grade them based on the bulk of disease. If low-grade tumors can benefit from liver transplantation, liver mets, even with extrahepatic disease, some of them may benefit from liver transplantation if appropriately downstage. But high-grade tumors typically should only get chemotherapy or liver resection. Liver transplant is not indicated. And of course, we all know about the big index case of NET getting transplanted. This again is important about the quantity of life, what you can add in life. Although we added only 2 years to his life, in that 2 years he was able to come out with an iPad, create the iCloud, and change a lot of the world as we know it. So clearly, that transplant did have a lot of benefit to mankind, if not for this person. Coming back to my summary slide, there is a definite role for surgery in liver transplantation. The impact comes after 5 years. We do need to treat our patients individually and increasingly as part of a larger group. Thank you so much.
We can have questions and comments from the house.
Thank you so much.
Okay, thank you so much. We move to the next talk.
So next, the speaker is Dr. Akash Jha. He is a professor in Department of Medical Oncology, NCI, AIMS, Jhajjar. And the topic of discussion is on metastatic liver disease in cirrhosis and without cirrhosis, how to manage.
Thank you. Good evening, everyone. So my topic of discussion is metastatic liver disease in cirrhosis and without cirrhosis. So I'll be mainly concentrating on cirrhotic liver. Without cirrhosis, as we all know, it is like any other garden variety management. Why we are discussing it? Because most of the studies or most of the trials have excluded patients with cirrhosis for obvious reasons. You can see impaired hepatic functions will lead to a significant limitation of uses of chemotherapies, surgeries, other interventions. So there are so many chemotherapy drugs, they are activated in liver. There are so many drugs, they are getting deactivated in liver. And besides other drugs there are which lead to hepatotoxicity, and sometimes if there is liver dysfunction pre-existing, there is a problem with the administration of the drugs. So because of all these limitations, most of the trials have excluded patients with cirrhotic liver or patients with who already have a dysfunctional liver, decompensated. If you see the secondary mets in liver, this is a large data. By sheer number, lung is the largest, although only 5% is metastasizing to liver, but because the lung carcinomas are so large in number, if you talk about the numbers, then lung is the most common. But if you talk about the site, the most common sites are colorectal and breast and pancreas. So pancreatobiliary, maybe GB will be another factor in our reason. So pancreatobiliary, colorectal, breast are the most common sites which have some secondaries in liver. So why do have a high incidence of liver secondary? This is very well known. The liver has dual blood supply, and because of that, very high chances that the metastatic seeds will move to liver and then they grow there. There has been a lot of controversy since very start from 1969 to multiple papers initially showing that cirrhotic livers have a less chance of secondaries from other malignancies, probably because of it is not an ideal microenvironment for the tumor cells to grow because of fibrosis and other things. There are multiple contradictory studies, although this JAMA paper does say that in a large number of autopsy, in samples post-autopsy, they found that both have equal incidence. So it's very hard to say if it is because of cirrhosis, the chances are of secondaries going to liver is less. This is what I mentioned earlier. For non-cirrhotic liver, if there is a secondary to liver, all the management is according to the management, standard management. If it requires surgical resection, if it requires chemotherapy, standard chemotherapy, it will be given as it is, as if the meds is to any other site. So that's not a problem. But for cirrhotic liver, what is the problem? As you see, if the worst situation, if the liver is decompensated, there is an elevated bilirubin, AST, ALT is deranged, all these patients have very high chances of grade 4 side effects. So in a decompensated liver, especially in the setting of cirrhosis, we have a problem with chemotherapy. You see, there are many drugs, especially taxanes, if you see, they have a chance of fluid retention. And then again, in the setting of cirrhosis, that can be a problem. Another problem that we do encounter in cases of cirrhosis with secondaries is many a times they are associated with viral hepatitis. And there is a significant risk of viral reactivation due to chemotherapy. It is not only rituximab or other drugs, chemotherapy also leads to a significant incidence of reactivation, more so with hepatitis B, that is more fatal at times. Even hepatitis C gets reactivated. And we need to be very careful about this viral reactivation syndrome. If we must check it at baseline, and if required, we should start chemotherapy, drugs, viral reactive drugs in time. If you talk about the drug safety in cirrhosis, these are the multiple drugs that are being used in those tumors that are metastasizing to liver. Most of them are safe to use unless the liver is decompensated. In compensated cirrhosis liver, the cirrhotic liver, there is nothing to worry. Only two drugs, oxaliplatin and irinotecan, they have a limited number of this incidence, small incidence of veno-occlusive disease and steatohepatitis. We need to be careful about it. If you talk about surgery for METS resection in cirrhotic liver, obviously that is a major problem. We need to understand the functional liver remnant. We need to understand the baseline liver functions. And if it is compromised, portal venous embolization is one technique that seems to be helpful in such cases. A longer interval from preoperative chemotherapy and liver resection is another thing that is found to be helping in multiple trials. We need to understand for a normal liver, the FLR can be around 20 to 30%, but for cirrhotic liver, it has to be 40%. And for those patients who are getting systemic or perioperative chemotherapy, like in colon, it has to be 30%. This is the summary of all the things we discussed in cirrhotic liver. All we have to understand is the first thing is that the liver is decompensated or compensated. If the liver is decompensated, most of the time we are not able to go for any form of definitive treatment. It is most of the time it is best supportive care. If it is compensated, there is liver functions are doing fine, we have to understand and that it needs very close monitoring. We need to be sure about liver dysfunctions and the other comorbidities that the patient can have, and we have to monitor it very closely. And the drugs that we choose. So except oxaliplatin, irinotecan, that is, those two are important drugs. Otherwise, all our drugs are okay to run. So, thank you.
Any questions from the house?
So if the primary is resectable, say if you have a primary in colon, the patient is cirrhotic and has a single metastasis, then what would be the best strategy?
Well, if the primary is resectable, and then we have to see if the oligometastatic disease in liver, we have to discuss its MDT and we have to see if it is resectable or not. Upfront resection is a fair option. If you feel that the resection is difficult at that time, we can go for perioperative chemotherapy. After that, we have to monitor the size of the liver lesion very closely, and as soon as it is resectable, we should go for a hepatectomy or metastatectomy, along with addressing primary disease.
Any comments from Dr. Anil Agarwal, sir?
Yeah, I think, as you said, but it will depend on where the primary is, because I think if it is cirrhotic liver, but there is primary, let's say it's colorectal, and it is resectable, then you don't have to wait. I think you can do it either as a synchronous resection also, or subsequently. Similarly for some of the other lesions. Whereas, so this will not qualify as what we talk about oligometastatic, because I think in some of these tumors, it is well defined that if there's a metastasis to the liver, that is comes in the resectable range. So I think we'll have to define it in that manner. So I think we would go ahead and resect it, and depending on if it is a small resection which is required, then we would do synchronous. But if it's a major hepatectomy it is required, then most of the time it is that you resect the primary, give adjuvant treatment, and then go in again. Thank you.
Thank you, sir.
Thank you.
So for the last speaker of this session. I call upon Dr. Amrish Sahni, who is a senior consultant in BLK Max, and he'll be taking the liver quiz and give us the carry-home messages for this session.
Good afternoon, everyone. So after the exhaustive discussion, let us face few questions followed by the protocol. So here is the routine patient coming to our OPD. Which one of the following statement is false? Cholecystectomy is recommended in patients with polypoid lesion of the gallbladder more than 10 millimeter. B, if patient has 6 to 9 millimeter polyp lesion in gallbladder and one or more risk factors for malignancy, cholecystectomy is still recommended. If patient has no risk factor for malignancy and the polyp size is less than 5 millimeter, follow-up is still required. If polyp grows by 2 millimeter or more within 2 years of follow-up, then the current size of the polyp lesion should be considered along with the patient risk factors. So which of the following is false? So this is absolutely correct statement. Cholecystectomy is recommended in patients with polyp lesions of more than 10 millimeter. The answer is C. So the answer is C. The follow-up is not required if there is no risk factor for malignancy. Here the catch is being an Asian is a risk factor for malignancy, so Indian patients will be followed up. The second question, coming to second question. Please come to second. Yeah. So 45-year-old female with chronic diarrhea and flushing was diagnosed to have a primary ileal net with liver metastasis. Histology shows grade 2 tumor. Her symptoms was well controlled on somatostatin analog. 2D echoes normal. Now she has presented in OPD for evaluation. So what will be the ideal next step? A, continue SSA at regular interval and no further treatment. B, refer to surgery for resection of primary tumor followed by surveillance, imaging and liver transplant evaluation. C, systemic chemotherapy, and D, everolimus. So, yeah. So we will refer the patient to surgery because whenever possible, curative intent should be there to treat neuroendocrine tumors. Question 3. So which of the following statement is false? At the time of diagnosis of neuroendocrine tumors, more than 50% have already liver mets. Liver metastasis is major prognostic factor in natural history of NET. Biopsy from liver metastasis is good enough to assess tumor grade. SSA controls symptoms in carcinoid syndrome but do not improve survival. Yes, so the answer is quite obvious. D, it has been shown in recent trials to improve survival as well. So my next slide is on the protocol. Can I have my next slide? It's not, yeah. Can I have my next slide? So a patient comes to OPD with a triple phase CT scan showing an ansic lesion in liver and AFP is normal. So we biopsy such patients to see what is the tumor nature. It comes out to be neuroendocrine tumor. We grade the tumors and go for the nuclear imaging like DOTA knock or DOTA talk. And if the primary is resectable, it should be resected in grade 1 and 2 tumors. In grade 3 tumors, if the primary is causing symptoms like obstruction or bowel ischemia, or jaundice in pancreatic net, it should be resected. And for liver metastasis, grade 1, if there is this is the protocol.
No, you don't have the slide going on, so you can just spell out the
so in grade
take-home message.
So grade 1, there should be curative intent. Primary is resected, and liver metastasis should be resected if it is resectable. And if it is oligometastasis, RFA or TACE or FAIR can be offered to the patient. If the load of liver metastasis is high, like type 3, in there also 2-stage surgery can be done, or PRRT can be given to the patient. If the disease is still progressive, then chemotherapy has to be given. In grade 3 tumors which are aggressive, systemic therapy like capecitabine and temozolomide in pancreatic net has to be offered. In rest of the tumors, platinum-based therapy has to be offered. Liver transplantation is with the curative intent can be done in less than 1% of the patient with grade 1 or 2 tumors. And this is all. I'm sorry they were not able to pitch in my slide. Thank you very much.
Any comment from the panelist? Anything? No. Thank you. With that, we come to the end of the session.
I invite the chairpersons, moderators, and the speakers of the session to please join us on stage for a group photograph. Next, we have a keynote lecture by Dr. G.V. Rao. The chairpersons for the session are Dr. Amit Agarwal from Indore, Dr. Sahaj Rathi, Professor, Department of Gastroenterology and Hepatology, PGIMER, Chandigarh, and Dr. Khalista, who's a consultant from Indonesia, and Dr. Kishore from M.I.C.E.
Good afternoon, everyone. May I request Dr. G.V. Rao to please start his lecture.
Thank you so much. At the outset, let me thank Professor Sareen for the honor of this podium this evening. Though most of the subject was covered with the initial speaker, I'll just try to look into how we can give an overall gist of what is happening in gallbladder cancer. The aggressive nature of the tumor, delayed presentation, poor survival and quality of life, and lack of high-quality randomized trials contributed to the nihilistic halo encircling gallbladder cancer, and none of the advances in oncology have been exploited enough to shatter this nihilistic halo that we have. The overall survival of these patients continued to be less than 20%, and the question that is repeatedly asked is, can newer insights improve the outcomes of these patients with gallbladder cancer? When we mean outcomes, we mean survival and quality of life. Carcinoma gallbladder, majority of them seem to be incidentally detected following cholecystectomy or detected on imaging, sometimes incidentally. The only way to prevent this should be to do some sort of cholecystectomy. Now, prevention remains the least explored option to reduce the gallbladder cancer-related mortality. Prophylactic cholecystectomy in high-risk groups is a cost-effective option. Basically, large stones, associated polyps, non-functioning gallbladder, porcelain gallbladder. Young patients, expected life of more than 20 years, strong family history, and geographically high-risk areas. And there are several red flag signs which can be taken into account to consider these patients for an elective cholecystectomy. All this aside, if you look at the dominant pathway, most of them seem to be secondary to gallstones. Based on this, is prophylactic cholecystectomy justified in silent gallstones? Now, this is some literature, this is a debatable issue. There is a strong proponents who feel that prophylactic cholecystectomy should be done, especially in some high-risk areas to prevent this gallbladder carcinoma. Survival and quality of life, of course, are related to the extent of the tumor and also the treatment modalities that we follow in this gallbladder malignancy. The survival seems to be dependent on the stage of the malignancy. More the advanced stage, the survival is very, very poor. And of course, the quality of life seems to be dependent on the various treatment modalities that we have, which include surgery, radiation, chemotherapy, immunotherapy, endotherapy, and targeted therapy. Surgery seems to be the gold standard as in today. There are several factors influencing this, including the functional status of the patient, extent of the surgical disease, and anticipated post-op outcomes. Basically, in patients with carcinoma in situ and tumor which is invading the lamina propria, simple cholecystectomy seems to be adequate. But all tumors beyond this, the management seems to be controversial, debatable, and we have so many randomized controlled trials that come in to show which type of treatment should be included in this. Incidentally detected carcinoma gallbladder increasingly being detected. Most of these patients are early, and some of these patients are so early that the survival rates are almost close to 100%. Extended lymph node resection is not routinely indicated in these patients. But those inviting beyond T1B, now these are the patients who who should undergo high quality cross-sectional imaging. The type, extent, and type of timing of re-resection remain controversial in these patients. Now, whenever we're doing re-resection, these should include portal lymphadenectomy and excision of all the lymph nodes in the hepatoduodenal ligament. Major hepatectomy and bile duct resection is not routinely indicated unless and until there is required to achieve an R0 resection. We keep talking about port site metastasis, which is about 10% in laparoscopic resection, which is almost similar to what we see in open surgery. Routine resection of port sites does not affect survival in current clinical practice. Lymph nodal harvest, higher number, better the thing, but the average number that is detected is about 6 lymph nodes are required to be harvested during these procedures. Hepatectomy versus cholecystectomy in T2 cancers, there is debatable. Actually, this is a huge meta-analysis which has shown that the peri-op long-term outcomes of hepatectomy and no hepatectomy were almost comparable. Wedge resection, as Dr. Anil has shown actually here, is the one with the procedure which is done. Actually, this is one of those procedures actually done laparoscopically. Can we run this video, please? This shows actually how we dissect out the hepatoduodenal ligament, all the nodes of the porta and the hepatoduodenal ligament, and subsequently also do the wedge resection of the It was running when I ran it here, okay? Fine. ICG seems to be coming into clinical practice in a big way. This is to identify the biliary system and also pick up nodes which are not conventionally picked up in conventional imaging. This has just come into clinical practice, and I think we will see more and more of this in clinical practice. Laparoscopy, as Dr. Anil was mentioning, for benign diseases, absolutely it is the gold standard. It provides clearer surgical field and detect liver and peritoneal metastasis that are difficult to detect preoperatively, reducing the incidence of unnecessary laparotomies, decreases the postoperative complication, accelerates rehabilitation by reducing the incision, alleviating pain, reducing blood loss, and promoting early mobilization of these patients. And it also helps to initiate earlier adjuvant therapy, which could improve the quality of life and prolong survival in these patients. Robotics and laparoscopy seem to be getting more and more into clinical practice. The outcomes are comparable to open surgery. Current census is still controversial as regards to advanced gallbladder cancers. The risk factors for recurrence are obviously T3 lesions, N1, or lymphovascular invasion. Patients with R0 resection, the presence of more than risk factors, the risk of local regional recurrence increases. And for these patients, additional therapeutic consideration has to be considered. Gallbladder carcinoma with jaundice, gallbladder cancer presenting with jaundice, these are uniformly fatal or still potentially curable. Actually, these patients who present with jaundice is a powerful clinical sign of inoperability, advanced disease, low resectability rates, high R1 dissections, and increased morbidity and poor outcomes. With gastric outlet obstruction, abdominal lump, weight loss, these are very unlikely to be resectable. Lymph nodal involvement, adjacent infiltration indicate poor survival, but obviously if the functional status of these patients is good, these can be resected as shown by Dr. Anil in the earlier presentation. Now, if you see the surgical resection with curative intent has the survival benefit compared to those with unresected disease and palliative intervention. Now, unresectable palliative groups who received chemotherapy showed improved survival in these patients. The recurrence is quite high in this patient, be it loco-regional, distant, or both sides. And we talk about adjuvant therapy in these patients. Now, this adjuvant therapy seems to offer potential solution and improve overall survival. Lack of high quality data, there are 4 randomized trials which support this adjuvant chemotherapy, and we have the safety profile of this seems to be very, very high, and there is a lot of data to show that adjuvant chemotherapy does improve the overall survival and quality of life in these patients. Now, does neoadjuvant therapy improve outcomes in this patient? The paucity of high prospective studies, several chemotherapy regimes are recommended by NCCN, and APB-HPV-sponsored consensus meeting advocated for neoadjuvant therapy, potentially to downsize the tumor and avoid unnecessary surgery in those occult metastases. Neoadjuvant therapy improves the resectability in some of these patients with unresectable gallbladder cancer. Resection after neoadjuvant therapy is feasible and may improve survival in a select group of patients. However, we require more studies to show this. We have this meta-analysis or a systematic review of 8 studies which shows that there is insufficient data as on today to support routine use of neoadjuvant chemotherapy or neoadjuvant chemoradiotherapy in advanced GBC, as this has benefited only a very small segment of these patients. But as on today, a lot of trials seems to be going on regarding neoadjuvant therapy for these patients. Segment 3, cholangiojejunostomy, which was the standard of practice for all inoperable cases earlier, is no more practice in clinical practice. We have given up because of advances in endotherapy and radiology. Surgical palliation is basically in terms of gastrojejunostomy, and there are empty number of procedures that are done to palliate these patients with advanced malignancy. PTBD is one of these procedures. This has got high technical success, but the morbidity related to the catheter seems to be very, very high. Though the procedure has got high technical success, PTBD does not translate into improvement of quality of life. So ERCP came in a big way, and it seems to be the gold standard, minimally invasive in the management of palliation of these patients. All patients associated with jaundice, cholangitis, pruritus, endoscopic biliary drainage frequently preferred procedure to improve quality of life and prolong the overall survival. Uncovered biliary stems is what is practiced to prolong, which has longer patency and lower risk of migration, and we need at least to drain more than 50% of the liver volume for the patient to be comfortable. Now, we have a comparative trial between PTBD and ERCP, which shows superiority of ERCP over PTBD. Endoscopic ultrasound has come in a big way to palliate these patients with obstructive jaundice, and it is done when ERCP is not feasible. Whenever we have altered anatomy or failed to cannulate in tight strictures, the choice among the EOS procedures seems to be very, very high, and all these procedures are seem to be very, very safe. Now, the surgical outcomes are best whenever these patients undergo EOS drainage vis-a-vis ERCP drainage. There is some data which is coming up to show that all these patients who undergo EOS guided drainage seem to do better surgically as compared to PTBD or ERCP. So conventionally, whenever we have this patient with obstructive jaundice, it is all depends on the expertise, the PTBD, endoscopic ultrasound, or ERCP, but it seems to be EOS superior to ERCP, superior to PTBD as in today in current clinical practice. Endoscopic placement of enteral stent was a gastrojejunostomy, increasing role in current day clinical practice. Though it is slightly more expensive, these are seen as good palliative measures for patients with gastric outlet obstruction. Celiac ganglion neurolysis, again, limited role, but often practiced in our patient has intractable pain. There are other multimodality treatment that are often done to palliate these patients, including radiofrequency ablation, microwave ablation. All these are done in sporadic cases in patients to palliate these patients, including a limited role of intraarterial chemotherapy for these patients, or some of these patients are subjected to hypothermia and intraoperative and chemotherapy to palliate these patients. There is no role of HIPEC in gallbladder malignancies as on today. It has some role in HCC patient, but does not have any role in gallbladder malignancies. So molecular profiling, previous speakers have stressed on this. Precision medicine for advanced or refractory gallbladder malignancy is an exciting area. It involves targeting specific molecular alterations with immunotherapy, and a lot of these have been targeted, but it's still in infancy, and you've seen a lot of data that is presented earlier. Now, these biomarker-driven clinical trial designs are what we expect in future to change the entire concept, and there is some data to show that these immunotherapies have got better role in clinical practice. Augmented reality is one such specialty which is come into clinical practice. It allows precise pre-planning for surgical resection with superimposed intraoperative imaging. Technology takes multiple preoperative images which are integrated, 3D reconstruction done, followed by preoperative planning and incorporated into operative data. The intraoperative procedures are superimposed on this. This aids in visualization and helping see through the structures. This is just to show you the integration of preoperative and intraoperative data which is done, which allows, like a Google map that we have, it drives through the procedure, gets good R0 resections, decreases the amount of blood loss that we have, and it is likely that more and more of these resections could be conservative as compared to radical resections that we do. And it improves in decision making, decreases operative time, decreases complications, improves surgical precision of tumor resection, surgical safety, and we keep increasing the indications of these patients. AI in CA gallbladder, still in infancy, may assist in locating and identifying structures in complex surgeries. Preoperative visualization, 3D visualization and printing is coming up in a big way. It also could help in intraoperative care and also in postoperative care, especially the radiomics. The goal is to achieve better individual healthcare plans in these patients. Now, integrating genomic and molecular targeting information and clinicopathological features will enable precise and personalized surgery with the aid of surgical technology enhanced with 3D imaging, augmented reality, virtual reality, and MR modalities. There's a lot of data that is coming up to show that AI can help in a big way. This is one such paper which shows that it can help predict prognosis of patients with gallbladder cancer. Again, a beautiful paper which has come from PGI Chandigarh in association with IIT Delhi, wherein the radiologists are able to pick up gallbladder malignancy based on the ultrasound images that were pulled up. Beautiful study which has come up from PGI Chandigarh and AIMS. Biology seems to dictate the prognosis. Given the importance of tumor biology, future resources for investigation of gallbladder carcinoma should be directed towards study of emerging techniques for early diagnosis, as well as development of novel, more efficacious systemic strategies. Now, does psycho-oncological interventions help in these patients? There is data to show that use of psycho-oncological interventions can reduce psychological burden and increase the quality of life of these patients receiving just standard of care. And also, if these patients are subjected to counseling adequately, it has shown that the anxiety, depression levels are less in these patients, and also the sleep disorders are less, improving the quality of life in these patients. Surprisingly, when you incorporate artificial intelligence into this, looks like the chat box can do better counseling than the humans. It's a beautiful paper which shows that if these patients are subjected to chat box counseling, these patients seem to be doing very well. Artificial intelligence, the lack of data validation, heterogeneity of clinical training data, quantification of severity and extent of disease is difficult. And who will take the responsibility? Will hospitals, government, and even individual physicians purchase or license these algorithms? Legally, who would be responsible for patients that are incorrectly diagnosed as cancer or missed in these tumors? Or you're sitting in the outpatient, you want to tell the patient that I'll just go back and come back and tell you after I take the consultation of artificial intelligence? Or what if your system crashes so the decisions are delayed? Or what if the systems are hacked by the counters? For all this, actually, there's a competing technology of natural intelligence which seems to be competing with this. Surprisingly, if you see the science fiction movies, you have an extra hard disk to speed up your own thought process. This people thought it's an absurd idea, but there seems to be good thing that is coming up into clinical practice of memory enhancement trials which are getting into humans. So gallbladder cancer, the formidable disease, survival and quality of life are interrelated. The survival depends on the stage of presentation. Surgery is curative but challenging, better outcomes with laparoscopy and robotics, and we seems to be doing more radical procedures in current day clinical practice. EU's guided biliary drainage appears to be superior to ERCP and PTBD because it improves the quality of life and decreases the morbidity in these patients. Enteral stent and EU's GJ offer better quality of life vis-a-vis gastrojejunostomy. Role of neoadjuvant therapy needs to be requires for the trials. Adjuvant therapies seem to increase the survival of these patients. There is increasing role of AI and augmented reality in current day clinical practice. Targeted therapies are offering renewed enthusiasm among oncologists with rapidly evolving landscape. The clinical trial should continue to assess how future treatments impact quality of life. Palliative care, supportive oncology should be an integral part of patients' care. Multidisciplinary, systematic global approach to initiate collaborative ventures to understand epidemiology, standardize management strategies, conduct multi-centric trials with new therapeutic agents, and initiate preventive measures would pave way for the improved survival and quality of life in these patients. Thank you so much once again. I take this opportunity to invite all of you to the ISGCon at Hyderabad.
Thank you, Professor Rao, for an excellent overview of carcinoma gallbladder. Any questions or comment?
Dr. Rao, you asked that neoadjuvant therapy in selected group has some benefit. Which is that group?
Now, see, actually there is, the huge systematic review has shown that it does not have any benefit in this. But again, now we have 2 or 3 more trials which have come, which have shown that these patients have benefit, especially the T3 patients seem to have some benefit in this.
Thank you.
Thank you so much, sir, for an excellent keynote address. Thanks a lot.
That was a wonderful session. Now, next we have, the next session we have the topic, tear and TACE and other modalities in HCC with PVT tumor thrombosis. I would like to invite the chairpersons, Dr. Chandan Guha, Professor of Department of Radiation Oncology, Montfort Medical Center, Albert Einstein College of Medicine, Bronx, New York. Dr. Sanjay S. Negi, Principal Consultant and Head, GI HPB Surgery, Yashoda Hospital, Ghaziabad. Dr. Umesh Goyal, Professor, Department of Gastroenterology and Hepatology, Danan Medical College and Hospital, Ludhiana. Dr. Supriya Malik, Professor, Department of Radiotherapy, AIIMS, New Delhi. So Dr. Andri, President of Indonesian Association of Study of Liver, and Dr. Amitav Goswami, Senior Consultant and Head of Gastroenterology, Swagat Hospitals. The moderators for the sessions would be Dr. Shamim A. Shamim, Additional Professor, Nuclear Medicine, AIIMS, New Delhi. Dr. CPS Chauhan, Director, Interventional Radiology, JP Hospital, Noida. Dr. Ajit Yadav, Professor, Department of Interventional Radiology, Gangaram Hospital. And Dr. Narendra Chaudhary, Senior Consultant, Hepatology at Matanda Hospital. Thank you. I request the chairperson to introduce the speaker.
Dr. Basil is the most senior guy, intervention radiologist in the country. Welcome, sir, to speak on this favorite topic, tear and trace and other mortalities in HCC with portal vein thrombus.
Thank you, and thank you, Dr. Sareen and Amar and everybody and ILBS for having me here. So let's quickly talk through what the current status is and how do we look at treatments for advanced HCC, and that specifically is in the subgroup in which there is portal vein tumor thrombus. We all know what BCLC has advised, and the standards of immunotherapy have overridden everything else. But it was because of a failed trial that TARE failed to actually make it to the BCLC recommendations. Even though it was a trial which was matched to see superiority, and it couldn't make it. So we looked at the trial and why this failed. The most important point in the SARA trial which led to failure was the extreme heterogeneity of the way the TARE was done. And I've been talking about this at different meetings when I get the opportunity. The point is that if you've got good amount of dose inside and you've got good delivery of the dose as you planned it, the survival goes to 24 months compared to just 6 months. And the entire cohort was 9 months, if you remember, in the SARA versus sorafenib, which was also about 9 months. So that's where the trial failed. And then if you look at a group in which if you see that the tumor burden might be slightly lesser, and if you have a favorable ILBS score, but one of the most important factors again became the tumor absorbed dose. If you're underdosing, you're doomed to failure. But if you succeed there, you could go even up to 3 years. So we can understand why TARE, if not done properly, is certainly not going to give us the results, but it has to be done appropriately. Looking across the other recommendations, not too long ago, just 3 years ago, we had this publication where if you look at the recommendations of how to manage advanced HCC with portal vein tumor thrombus, the effort seems to be that treat loco-regionally, try to downstage and get them to surgery if you can. And using whatever armamentarium you have, and all of them virtually fit in. If you look at the recommendations that came out of China, they even talked about hepatic artery infusion, and they said with reasonably good level of evidence, up to type 4 PVTT, but with a preserved liver function, one can do infusion chemotherapy. TACE was recommended in patients who have a lesser burden of portal vein tumor thrombus, that's VP1 and 2, and a child's PUA. If you combine it with radiotherapy and TACE is still being used, the recommendations were stronger, and with lesser evidence, molecular targeted therapies could also be coupled with TACE. There was a strong negative that was published, and it said that child's B or advanced PVT should not be offered TACE because the adverse effects would be totally unacceptable. TARE came up with blanket recommendations going all across the PVTT spectrum from 1 to 3 or 4 in fact, because there's a little classification difference between type 1, 2 and 3 and VP 1, 2, 3, 4. But they said that it should be offered in child's A patients. We know we've got a limit of up to B7. Let's look at some of the data. If you look at, therefore, hepatic artery infusion chemotherapy and look at how it is versus sorafenib, which was actually what all the data is. We don't have much against immunotherapy, but we have data in which 60% of patients were VP4, so at really advanced portal vein tumor thrombus. The median overall survival, time to tumor progression, objective response, everything was vastly superior in targeted loco-regional therapy infusion of chemotherapies compared to putting them onto sorafenib alone. If you were to combine sorafenib with HAIC versus sorafenib alone, interestingly, the maximum advantage gained was in the patients in which there was the highest tumor burden inside the portal veins. So if you were to combine, you would give patients with VP4 disease the best chance of taking advantage of the combination. So there have been a lot of publications that have come, about 4 or 5 of them since last 2018, and everywhere varying combinations of hepatic artery infusion chemotherapy have been used, and everyone has shown that the overall survival is significantly, very significantly superior to any other arm which was predominantly against sorafenib if that was used alone. So till atezobev came, when sorafenib and single targeted drugs were being recommended, if you look back on literature, I think HAIC still holds its own. And if you couple it with sorafenib, definitely VP4 patients would benefit, but even the others with lesser burden of tumor thrombus in the portal vein would definitely get benefit in combinations of HAIC with sorafenib. Now suppose we consider TACE. How does TACE show up in patients with portal vein tumor thrombus? Like we saw the Chinese recommendations where they said that TACE with radiotherapy is got a much stronger recommendation and evidence level. If you compare it to TACE alone, definitely it's superior, and interestingly, it reduces the number of TACE sessions. And the more you go into PVTT, the more is the advantage gained by the combination strategy. If you look at TACE plus RT versus sorafenib alone, again, there's a much higher radiological response rate, much better progression-free survival, longer TTP, longer OS, if you were to use TACE RT versus sorafenib alone. Again, trying to say that there's a lot in literature which is still saying that with PVTT also look at targeted treatments. TACE plus RT versus TACE plus sorafenib. Here, it didn't make too much of a difference, but effectively what they're trying to say is that combination makes sense in PVTT patients rather than TACE alone. And therefore, I think the statement logical would be compared to TACE or sorafenib alone, TACE plus RT probably is the most appropriate strategy. And logically, when it comes to considering CERT, the first question would come up, should it be CERT, should it be TACE? So here's a paper in which they looked at small tumors, but with portal vein tumor invasion, and they did CTACE and they did CERT. There were a much larger number of infiltrative tumors and tumors with vascular invasion in the CERT group. But they found that the progression-free survival was virtually double in the CERT group as compared to the TACE group. Again, trying to say that you get the dose of 200 gray, you will get a much higher and much better response than TACE in the CERT group. And that was further studied in RCTs where there was a dose-based strategizing of 2 groups in which a standard TARE was done and then the personalized dosimetry of more than 205 gray. And we can see the difference that personalized TARE versus standard TARE, there's a huge difference in the outcomes. And the dose at that point in this study turned out to be 205 gray was the cutoff factor. So we have tried to use that, especially when you're using the Raisen spheres. If you look at the results of downstaging, in patients with personalized dosimetry got a much higher incidence of downstaging, and patients with portal vein tumor thrombus getting downstaged. If you don't do a high dose TARE, I don't think we're going to get anywhere. No patient was downstaged unless you give high dose. And therefore the push towards ablative TARE and the effort is to go higher and higher and do a segmentectomy to try and destroy the tumor. This was a group in which there was PVTT going all the way up to MPV, that means VP4. But look at the median overall survivals of 45 months versus 18 months of ablative TARE versus conventional TARE. So trying to say that TARE also has to be done appropriately to get the best results. Similar data that came out of Korea, and again they said that TARE gives significantly better overall survival as compared to TKIs. Another study which talked about downstaging these advanced HCC, getting them transplanted and then looking at the results. And they had a survival of 61 months and 49 months. And these are patients with patients who are otherwise not anywhere in BCLC being offered any surgical strategies. And here using the glass microspheres, it was seen that the tumor absorbed dose is actually more than 400 gray. So basis how you do the TACE, basis which sphere you are selecting, the doses actually hold the key. And this was our experience, which I think Prashant must have talked of yesterday. trying to say that patients with advanced HCC downstage to transplant using TARE and SBRT, we were able to get a 5-year survival of more than 50%. And interestingly, patients who had PVT or did not have PVT tended to show near similar, obviously not absolutely similar, but looking at the disease burden, we were reasonably good at 5 years that we had many of these patients going, and they were behaving similar to patients who had not had PVTT at all and were transplanted. So we would say that CERT is an accepted form for BCLCC. Ablative CERT is the way to go. And there are now institutional experiences, not only ours, but other centers also across the world that are talking about SIRT with SBRT. Just to run you through a patient, this is a large HCC there you can see in the right lobe. It's going very near the liver. I'll just take a minute. It invading the portal vein tumor thrombus, PET avid, TARE was done, more than 200 gray. The PVT died, the liver tumor shrunk, and 7 years later, the patient is still alive with us after a liver transplant. So I would just conclude by saying that the ideal therapy for each patient currently now definitely is in an MDT setting, and I think we should move more aggressively to local regional therapies for treating patients with HCC and PVTT. Thank you.
Thank you, sir.
Excellent talk, sir. As Dr. Basil has the maximum experience in this, and Dr. Basil has done this TARE and TASE simultaneously, and I think nobody could have justified better than sir. So is there any question? We will welcome any question if have. Though sir has explained very well, I don't think there is any question left.
Sir,
but even then,
I can take one question.
Yeah.
Sir, do you think the atrium bits, specialized bits are there for better treatment in HCC with portal vein thrombosis? Some specialized new synthetic atrium bits?
So we've been using only Yttrium 90 commercially available glass or resin. There's some work happening in Tata. We were just talking. There's some indigenous development of beads, but it's very, very nascent yet. And holmium is something which is being talked about, but I don't think I'm in a position to really comment over superiority.
we have rhenium 188 at our Institute of Medical Sciences. So since yttrium is bit costly, but rhenium we are buying that generator that will last for 6 months. So that is quite affordable. So there is no actually that cost. Most of the time we talk about the cost of the TARE, but with rhenium I think the cost is very minimal. That will cost only 50,000 per patient.
Sir, any patient where you will consider TAE and not TASE?
So, to be honest, looking at all the data across, the first choice with PVTT we are still keeping as SIRT. If for some reason we are not doing SIRT, then I would say VP1, VP2, small liver burden, we would consider trying to do TASE. But if it's a larger tumor or VP3, VP4, and we've still got to do only loco-regional, we would consider transarterial infusion only and not go to the embolization.
Any experience in child B, TARE?
So, only B7, B8. I think anything more than that, they decompensate. They definitely decompensate. We've learned it the hard way early on in the experience, so I think Narinder would also agree that B7 is established cutoff.
So there is one question from the audience.
So, Dr. Baijal, as we have learned from you that dosimetry is everything, is equal to the response. So why there is a huge difference in the overall, let's say, we have discussed that more than 205 gray is, then we expect extensive necrosis and positive response. If we compare it with the SBRT, the dose is less, but we see the very good response, especially in the cases of portal vein thrombosis, and even for small SCCs, ablative SBRT. Why there is so much difference?
I know. So that's something which has always been a query for us as well. So the first thing we understand is to get enough homogeneous dose distribution of the radiation, we need a density of particles inside the tumor. And to achieve that, we've got to put in much more particles, and hence by the need of uniformly filling the tumor, automatically the doses are going up. For example, within resin and glass, resin does the same work at 205 and glass does it at 400. It's not that you need 400, it's because you had to put in 400 to get adequate distribution of your beads to really kill the entire tumor. And therefore, statistics just tells you that it's 400. Similarly, in radiotherapy, if you can really do focused, targeted therapy and probably the energy transfer into the cells at the cellular level to cause cellular injury, probably is much more focused in focused therapies, and therefore the results are better with lesser dose.
Thank you, sir. I think we can move on for the next speaker. So the next topic is SBRT alone or with other modalities for HCC with portal venous thrombosis. So I would like to invite Dr. Christopher Crane from M.I.C.E. USA to speak on the topic. Dr. Christopher.
Hello. Hello. I have a pre-recorded talk. Is that going to be shown? Yeah. Could I answer the last question from the radiation perspective? Hello?
Yeah, we can hear you, sir.
So there's a dose rate effect of radiation. Yttrium is a low dose rate delivery. External beam is high dose rate delivery. So the doses are not directly comparable. 100 gray of radiation is equivalent to 200 gray of yttrium because of a dose rate effect. I think to understand that better, you should probably pursue that topic. Okay. Could you play my video? Thank you.
We can't see your slides, Dr. Crane.
I pre-recorded my talk. Could someone please play that, or do you want me to talk with the slides?
Hello, my name is Chris Crane. I'm a gastrointestinal radiation oncologist for Memorial Sloan Kettering. Today I'm going to be talking about the use of radiation for patients with advanced HCC, with or without macrovascular invasion. The points I hope to leave you with are that based on randomized data, there's an improvement in survival when radiation is included, and that local tumor control up to 90% that's very durable with follow-up as long as 5 years have been reported that consistently reduces. Proton therapy has been around now for almost 2 decades, and 7 studies have been performed showing 90% tumor control with ablative dose proton therapy. The use of palliative doses of radiation has been shown in randomized trials from Asia as well to improve survival in patients who receive TACE first versus TACE alone. Recently in the US, we have completed and presented the results of a trial, RTOG-NRG 1112, that shows a median survival benefit with the use of SBRT in addition to sorafenib versus sorafenib alone. In comparison, the yttrium-90 or Y90 trials have all been negative compared to the same control arm, which is sorafenib. I'll just briefly show the 7 studies that have all shown consistent results with ablative dose proton therapy. For tumors less than 5 centimeters, there's a 90% local tumor control rate, and for tumors greater than 5 centimeters, it's roughly 80% tumor control rate. There's less liver decompensation with protons, and the long-term survival depends on selection for patients with less risk of underlying decompensation due to their liver functional status and other comorbidities. Here you see the survival curves from the studies that have been performed, and notably the local tumor control is all in the 90% or better range, and there's no drop-off after about 2 years follow-up. There's a translation to a survival benefit in these studies. As you can see, it's the ones that have included the survival curves up to 5 years, 40 or 50% in the more favorable patients. Here's our study from Mass General Hospital and MD Anderson that we performed with 95% local tumor control. So HCC is very sensitive to ablative dose radiation. There have been 11 randomized trials that have been conducted in Asia that have given palliative doses of radiation, which is about half of an ablative dose. that have shown a median survival improvement at 1 through 5 years. The relative benefit is greater with longer follow-up. These are patients that have had very advanced intrahepatic confined disease for the most part, tumors up to 10 centimeters, multifocal bilobar. The randomizations were all TACE versus TACE followed by 3D conformal palliative dose radiation. And as you can see in this forest plot, there was a major median survival benefit that was, on a relative basis, was improved with more follow-up. The responses were much better with 3D conformal radiation compared to TACE alone. If you want to see that in a survival curve, Kaplan-Meier summary, here you see the difference in survival, 55 versus 73 at 1 year, 20 versus 35 at 3 years, 21 versus 6 at 4 years. So the bottom line from this is that for these advanced patients, TACE alone is not enough, and that there are randomized trials that show that there's a median survival benefit to controlling the local tumor, and therefore it's an important component of treatment, one way or another, to control the primary tumor. Here's just an example of an advanced tumor that we treated that was not a candidate for anything else, invading the hepatic veins, extending into the IVC and into the heart. The patient was in liver failure due to hepatic outflow obstruction. We treated them with an SBRT technique, but over 25 treatments to protect the liver, achieved local tumor control, and the patient lived an additional 2 years, even though he was had hepatic failure due to tumor obstructing the venous outflow, and would have died within weeks. So obviously this is an extreme example, but radiation works very well to control these tumors. You know, whether you use a sophisticated technique as we did in this case, or a palliative dose, there will be a benefit to help patients live longer, and it's very well tolerated. Larger tumors are controllable with ablative dose radiation. Here you can see macrovascular invasion. Patients had 80 to 90% local tumor control in these studies from proton therapy, 90% on the top, and at MD Anderson, 80% local tumor control with macrovascular invasion. So the component of the tumor that invades the vein is still very sensitive to radiation. A prospective phase 2 trial was done at Princess Margaret Hospital in tumors that were up to median of 10 centimeters. The dose of radiation ranged from palliative to ablative in 5 treatments. They included patients with macrovascular invasion or not. On the upper panel, you see that there was 80% tumor control with lower doses of radiation, and 90% tumor control or so at 2 years using ablative dose. But still, either way, tumor control was very good, on the order of 70 to 90% depending on the dose of radiation. And you can see in patients with macrovascular invasion, there was a median survival of around 18 months that was about 40% at 2 years, which is pretty unique. In the literature, you won't find survival that's as good as that with any other modality. And this prompted a randomized trial that is RTOG 1112, which I'll show just a little bit in a minute. For that, I'll show you some other results with patients who had macrovascular invasion and had larger tumors up to 10 centimeters, local tumor control 80%, and at MD Anderson, this tumors greater than 5 centimeters had 80% tumor control. RTOG 1112 was an intergroup study from the US, which the randomization was sorafenib alone, the sorafenib versus SBRT followed by sorafenib in patients who could not have TACE or had macrovascular invasion. So these were patients who did not really have a standard option at the time. The control arm was the same as the control arm in all of the systemic studies at the time and the Y90 studies. The dose of radiation was reduced to make sure that it was safe for the liver, depending on the underlying liver disease and the volume treated. Here you see the patient characteristics. 73% of patients had macrovascular invasion, so a very unfavorable population. Child's Pew B7 and greater were excluded, and the median tumor size, sum of the diameters of all tumors, which could have been up to 3 satellites, was 8.2 centimeters in the sorafenib arm and 7.5 centimeters in the SBRT, followed by sorafenib arm. Here you see the progression-free and overall survival benefit, which was statistically significant. The trial actually had to be closed early due to the change in the systemic landscape as new regimens were introduced. The progression-free survival on the left, the curve shows that there was rapid progression in the in the sorafenib arm that was not as significant in the SBRT arm, and then on the right you see the survival benefit persisted throughout the duration of follow-up, with a very similar 2-year survival of around 40% that was seen in the pilot study from Princess Margaret. What this suggests is that patients tend to have rapid progression of the intravascular component, leading to a drop-off in survival that's pretty significant, around 30% in the first 6 months, and that radiation can prevent that. Regardless, this is the only trial in patients with macrovascular invasion that shows a survival benefit from a local treatment, and there haven't been any trials dedicated to this group of patients evaluating systemic therapies. Y90 has been around likewise for over a decade, and randomized trials have been conducted. They have all been negative, and the comparative arm has been sorafenib in each of the trials. The Suramic trial, which was conducted in Germany, showed no survival benefit. You can see the trials are completely superimposed. These are advanced tumors with a median of 6 centimeters size, multifocal at 83%, and again, no significant benefit. In fact, the Y90 group had 64% toxicity versus 53% with sorafenib alone. The surivinib trial from Asia Pacific, likewise advanced disease, liver confined in 42%, 24% had over 50% of the liver involved, macrovascular invasion 31%. Not even a hint of benefit in this study either. The Syrah trial was from France, of course, which showed no benefit in progression-free or overall survival benefit. Completely superimposed survival curves, and again, more advanced disease. The median size of the tumor was 7 centimeters with 60% macrovascular invasion, and the survival was no different. 8-month versus 9.9-month median survival. If you remember back to the RTOG 11-12 study, there was double that. So the main reference center for Y90 in the U.S. is Northwestern, and they've published their results with patients with macrovascular invasion, with main portal vein invasion of 4-month median survival, and with branch portal vein invasion 9-month median survival. So pretty close to doing nothing, I would suggest, with the use of Y90. Segmentectomy has been advocated in smaller tumors, and it's fair to say that the tumor control is pretty good at 2 years for tumors less than 3 centimeters. And this is just flooding a segment with radiation dose, causing complete destruction of the lobe, and also covering the tumor very well with this isotope yttrium. But if you look at, again, Northwestern's results, 30% local tumor progression in a study that included tumors up to 5 centimeters. So 30% local progression is much more than we would expect from ablative radiation, especially when 90% control is expected for tumors less than 3 centimeters. So that means greater than 3 centimeter tumors are not being controlled very well with Y90, and this is the reference center, really. Northwestern publishes most of the data. The same in the Legacy trial, which was a Northwestern-led randomized, single-arm, multi-institutional study had 28% local tumor progression. And if you assume 90% of the 3 centimeter and less tumors were controlled, that means probably more like 50% of tumors had progressed in larger tumors. And this is not hard to understand because this isotope, it only has a 2.5 millimeter range. There are electrons that come from an isotope, and the dosimetry will always suggest that there were parts of the tumor that are not being treated at all, and the tumor will just keep growing. So the results from yttrium-90 have shown significant limitations in that tumors 3 centimeters and less are controllable at probably 90% range, but that is true of anything that's given for a 3 centimeter or less tumor. But tumors that are more advanced than that just cannot be controlled at all because of the vasculature being incomplete and the feeding vessels not completely enabling radiation dose to go to the entire tumor. So the conclusions: proton therapy for HCC results in 90% tumor control. Access to this is limited, obviously, but this shows that ablative dose radiation is extremely effective for HCC. It doesn't matter how big the tumor is. Palliative dose radiation can improve survival over embolic therapies over TACE alone in 11 randomized trials that have been analyzed together. Ablative dose radiation versus sorafenib has shown a survival benefit in the worst patients that have macrovascular invasion, statistically significant improvement in survival. Y90 has been negative in 3 randomized trials and should not be used in patients with advanced disease, other than those that have a solitary lesion less than 3 centimeters. There's no evidence to support it. Thank you very much for your attention.
Thank you, Dr. Crane, for a wonderful presentation. Any question from the audience?
Dr. Crane, up to what volume of affected liver you will take for radiotherapy?
That depends on the underlying liver disease, so we always take into account whether they are fully compensated or decompensated. We express that by contouring the gross tumor and subtracting it from the normal liver volume. And the mean dose of radiation for someone with compensated liver disease can be 28 if it's given in 5 weeks, or 15 if it's given in 1 week. So the number of fractions is also a factor. The way that we can give a higher dose is to give more fractions. SBRT is typically 5 fractions, but you can give SBRT up to 25 fractions and get more coverage of the tumor safely. So larger volume tumors should really be treated with more fractions in order to achieve better tumor coverage and dose. The way that the RTOG study was done is that the dose was reduced and the fraction number was kept at 5. So the volume typically ends up being 2/3 of the liver needs to be protected for it to be safe 100% of the time.
And Dr. Crane, in NRG trial, the dose that was used is 27.5 GY to 50 GY. Such a heterogeneous dose, what is your take on that?
So that's a strategy that I don't use, and that is the full ablative dose is 50 gray and 5. That's equivalent to 100 gray. That's equivalent to 200 gray with Y90. But if we can't achieve a safe dose because of the tumor volume, the dose has to be reduced with 5 fractions. The other thing that can be done is that you can give more fractions and give a full ablative dose. So for instance, 75 gray and 25 fractions is the same as 50 gray and 5 fractions, and that protects the liver better. So I think the argument for reducing the dose is that the patients who have larger volumes have a worse prognosis, and I think the results do show that reducing the dose in these more advanced cases has been a strategy that's reasonable. I personally would rather give the full dose with more fractions, but both strategies appear to be very reasonable in these patients with underlying liver disease, and especially in the Child-Pugh-A6 patients who've already started decompensating. Being very careful with the liver dose is an important thing. And typically, we give use stricter constraints for people that have A6 disease.
Dr. Chris, you have shown in your conclusion slide that proton beam therapy response is more than 90%. Can you elaborate about this? You are talking about the partial response, complete response, or something?
No, I'm talking about durable, complete response for as long as the patient lives. I'm talking about giving an ablative dose, and these are 7 trials. One of them was our trial from MD Anderson. And in the more favorable patients from Asia, where the patients have lived longer, there's 90% of the tumors that never grow again for the duration of the patient's life. So that's a different way that most of these results are expressed, which they do not express local tumor control, which is a very important evaluating endpoint for a local treatment. So that's the translation for in response terms is durable, complete response for 5 years.
Thank you. So any other question? So I think we will move to the next talk.
Yeah. We are proceed to the case scenario by Dr.
Thank you, Dr. Chris.
Yeah. Thank you, Dr. Green. The speaker next, Dr. Divya Khosla, for the case scenario. The Department of Radiotherapy, Postgraduate Institute of Medical Education and Research, Chandigarh.
Good evening, everyone. At the outset, I would like to thank organizers for inviting me. And we'll be discussing a case of HCC with tumor thrombosis. And first, Dr. Ishank will present the case.
Good afternoon, everyone. Today's case is Mr. VK. He's a 76-year-old male, known hypertensive and diabetic. He had index presentation in November 2020 with loose stools, loss of appetite, and weight loss of around 15 kgs over the course of 6 months with generalized weakness. On examination, he had a palpable liver in which left lobe was firm. Right lobe was also felt 5 centimeters below the costal margin, and clinically there was no ascites. In his index presentation, an ultrasound was done from outside which showed a large heterogeneous lesion in the left lobe of liver with main portal vein, left portal vein and right portal vein thrombosis, likely tumoral thrombosis, and there was no free fluid in the abdomen. UGI endoscopy was done which showed grade 2 varices without any RCS, and a CT triple phase was done which showed a segment 2-3 lesion around 7.1 into 7.8 centimeter LR5, segment 4A lesion of 4.1 into 3.8 centimeter, which was also abutting the other lesion in segment 2, enhancing tumoral thrombosis in left portal vein, right portal vein and main portal vein, and AFP of 188 and PIFCA of 80,000. So in his investigations, platelets were significantly normal, 2,01,000, INR was 1.11, and in terms of liver function, albumin was around 3.01, and so the provisional diagnosis was HCC in segment 2, 3 and 4A with VP4 thrombosis, BCLC type C due to performance status 1. So he underwent SBRT therapy alternate days in June 2021 from 4th June 2021 to 15 June 2021 with 8 fractions of around 36, 40 gram and 32 gram. On follow-up in August, initially the size of the tumor was around same in segment 2-3 with intratumoral hemorrhage of around 4.5 centimeter. Segment 4A disease showed stable disease, but AFP and PIFCA had come down significantly. He was started on lenvatinib, but he was intolerant due to oral ulcers. In June 2022, he showed significant reduction in the size of tumor in segment 2-3, and there was a small lesion in segment 4B, which was LR4. Tumoral thrombosis was still present. In December, he was started on sorafenib, but he could not tolerate due to paresthesia. In December, the segment 2-3 lesion was almost not visible, and segment 4 lesion was small in size with no arterial phase enhancement. Segment 4B lesion had come down on its own, and it has changed from tumoral thrombosis with only chronic thrombosis in the portal vein. AFP has come down to 0.9. In follow-up after in September 2023, Also, disease is stable with AFP of around 1.1 and PIVCA of 74.
So would we discuss how to manage HCC with portal vein tumor thrombosis, role of SBRT, and the challenges with response assessment. So portal vein tumor thrombosis occurs in 35 to 50% of the patients with involvement of the main trunk in 15 to 20% of the patients. And it is a complex clinical and anatomical condition, including wide range of patients having different prognosis. And the treatment possibilities depends upon the patient's clinical features, tumor biological aggressiveness, underlying liver function, degree of portal system involvement, which is very important, local expertise and the modalities available at one's institute, and then the treatment preferences by the patient. Systemic therapy should be offered to patients with preserved liver function, child PUG A or B, and ECOG performance status 0 to 1, who have BCLC stage C. And decision making should be individualized and be best made in the setting of a multidisciplinary tumor board, and the treatment concept of local treatment plus systematic should be strengthened. So this is the treatment algorithm of HCC with portal vein tumor thrombosis, and the child PUG A patients with, they can be managed according to the type of PVTT. Our patient had type 4 and was given SBRT. He was put on TKIs but had poor tolerance to lenvatinib and sorafenib, and he's disease-free 2.5 years after treatment and doesn't want any medical treatment. So this was a much-awaited trial before immunotherapy. It did close earlier. It randomized patients to sorafenib and SBRT followed by sorafenib. And 74% of the patients, they had macrovascular invasion, with 63% having VP3 and VP4. And it was seen that with combination, the survival was better, and so was the progression-free survival. And when the analysis was adjusted for performance status and the degree of macrovascular invasion, so there was a significant improvement in the group which received SBRT and sorafenib. And this was the systematic review and meta-analysis which compared the various radiation modalities. And it was seen, though the survival was comparable, but the response rates were much higher in the group which received SBRT. Now, what is challenging is the response assessment after radiation-based therapies, because then the arterial phase hyperenhancement may persist for some time or for a year after radiation treatment. But it gradually decreases in intensity over time. If you see in this, after 3 to 6 months, you see a hyperenhancement, or you may see an area of hyperemia, which may be because of the SBRT-induced inflammatory response in the tumor and the surrounding parenchyma. But over a period of time, that gradually decreases, and you will see that the tumor is barely seen or it's very small in size, and the fibrotic changes may occur at the site of treatment. So for the residents, the imaging features which are suggestive of local disease progression after SBRT, they include the increasing size of the treated tumor or new or increasing intensity of the FE after the treatment. So as we were advised to involve chairpersons also, so my question to chairpersons are, what are the challenges associated with anticipated and response assessment after SBRT and immunotherapy? Because we know following SBRT, the arterial phase hyperenhancement may persist for some time, and with immunotherapy, there may be pseudo-progression. So what is the, what should be the timing of follow-up imaging studies in such patients? And what is the best response criteria to be followed in patients who receive this SBRT and immunotherapy?
This question is for chairpersons, not for the moderators. So you
the moderators cannot answer.
So a person from the radiotherapy can answer this.
I think MRI and CT both are used, but still it's difficult because of the enhancement pattern. It remains for at least 12 weeks. So radiologically it's quite difficult, but definitely clinical patterns and biomarkers we follow them up.
As per the Pratt guideline, we actually do scanning after 6 weeks of the radiotherapy. Before that, we can get the inflammatory changes, and the result may not be so appropriate.
And the studies usually recommend a period of 3 months at least post-SBRT, so that the radiation and induced inflammation should settle.
Yes, yes, that's more appropriate.
Yeah.
But if you want to do, 6 weeks is minimum, and 3 months is appropriate.
Now the question comes with the immunotherapy, because
why you want an imaging altogether? if you have biomarker, you are seeing there is a reduction in the level. Then if your imaging is already confusing, adding imaging at 6 weeks may not be very
That's what I
prudent.
asked. What should be the timing of the follow-up imaging studies? Because a lot of studies or a lot of people,
At least,
see
I think
3,
post
6,
SBRT
9.
for any way and any location, I think it should be 12 weeks.
See,
Not before
all the
that.
tumor are not having the raised tumor markers.
Yeah.
In those cases, we do need imaging modalities. Since I'm from the imaging,
But before 12
I'm
weeks
going
is very
to,
difficult to
I am going to
interpret.
defend this question. Yes.
I think what you're seeing is that there's residual feeding vessels that are resistant, and with time they atrophy. It's not really inflammation. The vessels are they atrophy after the tumor's gone, and that does take time. I agree, 12 weeks.
Thanks, Dr. Chris, for saving us. So, is there any question from the audience side? Please ask some question. Earlier I was asking Dr. Divya, organizer must have spent so much money on you. You are coming from Chandigarh, staying in the hotel and then going back on. So we must ask some question to
He
justify this.
already asked me before the session.
So I think we will move to the next
thank you very
session
much.
and talk.
So I welcome our new speaker, Reena Engineer, Professor Radiation Oncology, Tata Memorial Hospital, Mumbai. The topic is hepatoscope, what's new in literature.
Good afternoon, everyone, and I'm excited to be here. And we are living in indeed exciting times where treatment for HCC is continuously changing and improving. And here I need to discuss, after a wonderful lecture of Dr. Crane and Dr. Guha in the morning, yes, what is happening new where radiation is concerned. And this is an old slide of Dr. Dawson, and we, as radiation oncologists, we believe that the role of SBRT is there in all stages of management of HCC, whether it's early or whether till palliative. So there's SBRT can fit in every situation. And again, in every stage, we have to be cautious about the doses and where we do it, and how we do it. But then, of course, it has a role in every situation. And now I'm going to talk about the synergism of immune checkpoint inhibitors, because now immunotherapy has come in a big way after this I'm Brave study, and it is going to be there, and it will stay, and there'll be more and more drugs coming in the future. So we have to be geared up, and as radiation oncologists, we have to try many combinations, which will be the best and with to whom. And so how does immunotherapy and radiation, the synergism work? It was covered in morning by Dr. Guha, because the SBRT creates or triggers an immunogenic response, and this ushers the T cells CD8 into the tumor, and then again this activates the dendritic cells, and there will be various pathways which are activated, and which gives rise to the tumor kill. Enhanced tumor kill with SBRT, but there's also immunosuppressive effect of SBRT which starts coming in, and this is where the immune checkpoint inhibitors, the role steps in. And this is like the slide which shows that if we give SBRT without immunotherapy, these cells, CD8 cells, are inhibited, and so that we can expect some response. But when we add immunotherapy to SBRT, these activated CD8 cells, and there's a more immunogenic response and more tumor response. So, so now in the last 3-4 years, very small studies have come up with very few patients, and future there are more trials I'm going to discuss. So another advantage of SBRT is where we see many abscopal complete regression of the metastatic sites when we treat just the primary tumor. So this is, we call it as a bystander effect, or just a side effect where we see in few patients. So like in this patient which was published, but we don't see very often. But yes, more and more with immune therapy along with SBRT, we are going to see this. Another question is about the sequencing, how we should do. Now some data is coming up that concurrent may not be very good, it may be more toxic, but when SBRT is followed by immune therapy, then that is like maybe slightly more better rather than starting with the ICIs. But again, there is no concrete data to suggest all the sequencing, and future is going to be where more data will come up. This was another interesting study, was published in Lancet Oncology this year in February from China, and they used SBRT. These tumors were more than 5 centimeter and maximum of 3 lesions, and primary endpoint was to see that how many proportion of patients achieved the curative or the surgical treatment. And they gave TACE on day 1, followed by SBRT, followed by avelumab, which is, I think, available only in China. This is anti-PD-1, and it was administered every 14 days or 2 weeks. And there they've shown that excellent progression-free survival, overall survival. Look at the median overall survival is 30 months, and which is not seen in this group of patients. And local control rate is also very good. And there were 18 patients, and 55% of them were amenable for curative resection. 2 underwent resection, 2 underwent RFA, and 42%, that is 15%, had complete radiological response, and they opted for close surveillance. Though it's a small study, but then again, it was worthy of being published in Lancet, and this is going to be the future, and this shows that yes, the synergy can work to give a very optimal and good outcomes. So another very small study, this was published in 2019 with only in 5 patients, and combined SBRT with ICI, and then again overall complete response was 100%. Another small study by Juluri, again 14 patients, and they showed that when they combined SBRT with IPI and nivolumab, the outcomes were superior than nivolumab alone. This is another small study of 72 patients where they showed that SBRT, when combined with TKI, lenvatinib, was much more superior where progression-free and overall survival was concerned. Even in when there's a progression after on a systemic treatment, there is hope for these patients where we add in SBRT and the immunotherapy of camrelumab. I can't even pronounce this properly, but yes, this is going to be another, even in progression on systemic treatment, there is hope that we combine SBRT with this camrelumab, which will give better outcomes. So these are the ongoing studies with SBRT and immunotherapy. Many of them are dose-limiting studies. We at Tata also, we have just designed a study where we'll be starting with SBRT followed by atezo-bev in select group of patients, and we are going to see. There's urgent need of biomarkers. Despite all the things, we have to just rely on AFP concentration, ALB score, and PDL1 concentration is also being evaluated. And some studies are also looking at circulating DNA and microRNA levels. There is some data coming up that hexokinase 2 it shows radio-resistant tumors. And there's more small studies are coming of a few patients where it's showing synergism. Another interesting modeling study was done. So when in these patients, like when they have extrahepatic disease, and when we give radiation to all the sites, including the liver and the other sites, they showed that it may be with lower doses, but it is much superior than giving partial tumor radiation. So we should radiate to all the sites barring B with a lower dose, and that is much more, that can lead to a better outcomes. And there's a dose response. Dr. Crane has already discussed that yes, we higher the dose, especially in the larger tumors, more than BED of 78 gray should be achievable. Proton beam has been discussed. Liver brachytherapy is also coming in subset of patients, and even as ESMO guidelines, iodine 125 and HDR brachytherapy is also coming up in the big way. So here, SBRT with immunotherapy is the new kid on the block, and it's more and more studies are to be designed and investigated, and we need to also study the biomarkers along with it, probably with NGS. So this is the future. Thank you so much.
Thank you, Dr. Reena. So main fear with radiotherapy is decompensation of liver disease. Any comment on that?
So Dr. Crane has discussed, so we as radiation oncologists, we have to be very careful when we contour the tumor, and we have what the amount of normal liver volume has to be spared of 700 cc or more. So when we are careful and we restrict our doses to median doses of like less than 15 gray, we say, or 12 gray in some cases, then the risk of liver decompensation reduces to less than 15%. We do see the rise in by 2 points, but that subsides in the next 12 weeks. So we do continue to see the LFT, do the LFTs and check.
Any question from the audience? So Dr. Reena, I wanted to ask one question, though this is not related to your presentation and not related to academics. Your name is Reena Engineer.
Okay.
So why you have chosen
so I am married to a Parsi. So
okay.
Persians, when they came to India in 8th century, so they took up the names as per their profession.
Okay, that name is very confusing. You are doctor and your surname is engineer. Anyway, thank you very much.
Thank you. Okay.
Thank you, ma'am. So the last presentation of this session by Dr. Deepti Sharma. She will be talking on liver quiz and carry home message. Deepti.
Good evening, one and all. So let's start with the quiz. Quiz 1. BCLC-C subset of patients are not characterized by tumor thrombosis, lung metastasis, child C, and locoregional lymph node metastasis. So lot of confusion seems, or no confusion? No answers. So BCLC-C is characterized by either tumor thrombosis or distant metastasis or locoregional lymph node metastasis. Child C is in the BCLC-D. So answer is B. Sorry, answer is C. Quiz 2. In a patient with HCC with VP4 tumor thrombosis and lung metastasis, child's B7 with high risk esophageal varices and bleeder, the treatment modality is combination of atezolizumab plus bevacizumab, SBRT followed by TKI, TKIs alone, or best supportive care. Yeah, that's the right answer. Quiz 3. Non-classical radiation-induced liver disease is not characterized by increase in transaminases level, increase in alkaline phosphatase, elevated bilirubin level, and increase in child score by more than equal to 2 points. So we have two types of radiation-induced liver disease. One is classical and another is non-classical. In the non-classical, there is no increase in alkaline phosphatase. It is the classical radiation-induced liver disease where alkaline phosphatase is increased. So the answer to this question is option number B. Now the protocol for the patients with portal vein tumor thrombosis. So as we all know that the backbone is the systemic therapy with ICIs or TKIs, but in the patient with child's A who are resectable and with the VP tumor thrombosis of 1 and 2, the patient can be taken for surgery after neoadjuvant therapy or surgery followed by adjuvant therapy with the form of radiation or TACE. In non-resectable tumors with VP 1 to 3, SBRT or TAIR with plus minus TACE for the main tumor, and we can go for radiation therapy to the tumor thrombosis. For VP4 tumor thrombosis, SBRT to the tumor thrombosis with TAIR for the main lesion, or one can go for SBRT for the entire, that is the primary as well as tumor thrombosis. For oligometastasis, locoregional radiation therapy or plus minus microwave radiation therapy like for lymph node metastasis or lung lesions. For child's class B, VP 1 to 3, SBRT with tear or TACE. VP 4 tumor thrombosis, again radiation therapy with systemic therapy or in some patients symptomatic treatment. For child C, best supportive care or palliative radiation therapy. Thank you.
Thank you, Dr. Dipti. I think we can conclude the session now. This is the last speaker. Thank you.
Thank you, chairpersons, moderators, and the speakers. Now we move on to our next session, that is the National Academy of Medical Sciences lecture on management of portal hypertension in HCC. May I please call upon the chairpersons, Dr. B.C. Sharma, GB Pant Hospital, New Delhi, Dr. Alok Mishra, Consultant Department of Gastroenterology and Hepatology, Phoenix Hospital, Allahabad, Dr. Sushant Babbar, Assistant Professor, Dayanand Medical College and Hospital, Ludhiana, Dr. Amar Mukund, Professor Interventional Radiology, ILBS, and Dr. B.S. Rana.
So this is a lecture, NAMS lecture, and I have been given the opportunity to, organizers had said me to introduce the speaker, and it's a honor. I'm not to, the person who has introduced hepatology and gastroenterology to many of us, in fact all of us, and it is our gratitude to be here and to introduce Dr. Professor S.K. Sareen, Director, ILBS, to present this lecture. Sir.
Thanks, Alok. And National Academy of Medical Sciences is an umbrella under which all societies come, whether surgery, medicine, or any allied sciences. So I welcome you. Since I am associated with NAMS, I thought I'm not publicizing NAMS because that's not what my aim is. But to say that National Academy is the ultimate academy, it has about 1,000 fellows, about 2,500 members, and maybe associate members and associate fellows. So do join, and we need all kinds of people for National Academy who are amongst the top in the country. Second, I will briefly say that this is a unique course of multimodality which I have enjoyed myself, and I learned so much from allied branches. I one more time bring greetings from ILBS, and I'll touch on an area which I think is totally in infancy. I have nothing to disclose. I'll try and cover a few thought-provoking areas. The development of liver cancer and portal hypertension have a lot in common. So you know that when there is increased resistance, to overcome the resistance, there is extra blood flow, hyperdynamic, and this is due to nitric oxide overproduction. Then this leads to opening of collateral vessels, angiogenesis, and the same is the mechanism for development of liver cancer. There is increase in the immunosuppressive cells, and chronic inflammation leads to supports development of HCC. How do you assess presence of portal hypertension in an HCC? So vascular invasion increases portal hypertension, HVPG. Liver stiffness is not reliable. A liver stiffness above 25 overdiagnoses or underdiagnoses CSPH. Clinically significant portal hypertension means above 10 millimeters. Splenic stiffness may be fallacious due to portal vein thrombosis. So this is my thought and maybe some others. Every patient with HCC should have an endoscopy, especially if there is portal vein thrombosis. Even if platelets are above 150,000, even if LSM is less than 15, please do an endoscopy. And everybody who has above 25 liver stiffness, give beta blockers. Even if you are a radiologist or a surgeon, give beta blockers. This is not to oversimplify. You have VP1, VP2, VP3 and VP4. Those patients who have got VP4, 1 year survival is 1 in 5. Now, if somebody has portal vein thrombosis compared to no portal vein thrombosis, the development of high risk varices is more, and also varices may bleed more in these patients. I'll now say the management of these patients. Patients who are on propranolol up to 5 years, development of liver cancer is only 4%. But those who are not on propranolol, development of HCC is 20%. So all patients must require, because as I told you, nitric oxide and other VEGF are drivers for this. This is a new data. The HCC incidence on beta blockers versus control, there is a reduction by 13%. Propranolol does not help. Timolol does not help. Nadolol, which is not available in India, decreases by 26% and carbidiol by 38%. Give carbidiol to your patients of portal hypertension and with HCC. Now the outcome of HCC on selective versus non-selective beta blockers. So disease progression on beta blockers versus no beta blockers. It is reduced. This is to show you that patients who have got beta blocker usage versus no beta blockers, there is a significant difference. And when you go further down the line, the survival, there is an advantage. So people with portal hypertension, cirrhosis and HCC on beta blockers survive longer. So let us clarify this. Beta blocker is the mainstay for these patients. One more time, between selective and non-selective, like somebody is on metoprolol, atenolol, it does not help. You have to be on carbidiol, and carbidiol will give you a better and distinct non-selective, and lipophilic gives you better advantage. Now, how do you screen for varices and for primary prophylaxis? This is from a recent update in hepatology. If the LSM is 25 or less, that is for cirrhosis, a screening endoscopy, if it is less, is not required. In my opinion, a regular endoscopy is required. In fact, they have put an asterisk to say you should do endoscopy and no prophylaxis. I would say endoscopy and maybe if there is a PVT, do prophylaxis. Now, if you find esophageal or gastric varices, use non-selective beta blockers. Or if you have LSM above or equal to 25. So two groups. Even if LSM is low but you have varices which can occur, beta blockers. If you have above 25, everybody. And the drug of choice is carbidiol. If of course there is contraindication, then do band ligation. So screening and primary prophylaxis, there is no endoscopic band ligation. Remember, only non-selective beta blockers and only drug is carbidiol. So beta blocker therapy helps reduce incidence of HCC development, risk of first bleed and mortality in HCC. Let's see, a patient has bled what are the options there? Now, this is a patient who has beta blockers or EVL, sorry, this is not patients who have bled. This is a group of patients who had portal vein thrombosis, and in them 21% of the patients had portal vein thrombosis, and in them the primary prophylaxis was done. Patients who had EVL bled more than beta blockers, and the study was stopped. This is in a very small journal, but surprisingly this is the only study. We tried to do this study, but we could not because our resident did not at that time could complete it. But in my opinion, clear, no EVL for high-risk varices for primary prophylaxis. Now, varicose bleed prophylaxis I have already discussed. Now, a patient has come who has acute varicose bleed or had AVB and now is under treatment. So, what will you do? You will do band ligation, but also start or continue non-selective beta blockers. Now, what is the outcome? A patient who is Child's A but has no clinically significant portal hypertension, means portal pressure is less than 10. 5-year survival is 70% in such patients. If there is clinically significant portal hypertension, it comes down. This is not HCC. In a patient who has got HCC and his Child's A's, normal survival without bleed is 38 months. You can achieve that 38-month survival. But if the patient has bled, it comes down maybe by 1/6. Just 5 months survival in this patient. So prevention of first bleed is extremely important for us. If the patient has bled actively, I would put EVL. If it is gastric varix, then I will do glue injection. And in uncontrolled bleeding, tips can be given. Try to achieve 50% at least 2-year survival. Your patients must survive, and at least half of your patients must survive. Otherwise, they would die by 5 months. So try and improve that survival. Can you do tips in a patient with HCC and PVT? Yes, this data of 19 study, and this study was given to me by Vishnu, 937 patients, and half of them had less than 5 centimeter, and many more with portal vein thrombosis. Tips resolved bleeding, ascites. It was more effective in control of bleeding. There were no lethal complications. HE developed in 15 to 30% in 3 months. Complete response to the therapy that was being given, whether SBRT or TACE, could be achieved, and liver transplant in some of them could be done. Bottom line is, we are afraid that tips can cause a spread of the tumor, it can cause metastasis, it will not be possible, but now you see that a large number of patients can get benefit from tips. And there is Korean study also, which also says that tips is a good idea in these patients. Now, what is the relevance of portal hypertension in hepatic and extrahepatic surgeries? You all know this. Resection is safe, feasible if platelet counts are above 100,000. To me, this is very, very important, correctly done platelets, and HVPG is less than 12. Many people in UK would like 10, but many people would go up to 12, but not above 12. You can do indocyanine green. If the retention is less than 15%, it is pretty good. And sometimes if the pressures are about 12, 15, 16, you can do a TIPS prior to, let's say, CEO colon with mets in the liver, or there is an HCC which you want to resect, you can do, and there is no option of transplant, you can do TIPS. Now, the next question is immune checkpoint inhibitor and bleeding risk. This has been debated a lot, but I want to show this data that if the patient has portal vein thrombosis and he is on atezolizumab and bevacizumab, then bleeding is 14%. If there is no portal vein thrombosis, in IMBRAVE study, only 1% bleed. So we are over worried about bevacizumab in this, only 1%. Yes, if you have a patient, HCC, PVT, then giving this combo can precipitate bleeding. So give beta blockers and then start it. So all patients who are going to be on immunotherapy, or in fact any therapy for locoregional also, workup for portal hypertension is a must. Primary prophylaxis is non-selective beta blockers for all locoregional or immune checkpoint or TKI is mandatory. Endoscopies may be done at 6 monthly intervals on therapy so that pressures don't increase. And if patient has bled, then maybe bevacizumab can be withheld or alternatively done. Now, bleeding risk and management on ICI. If the variceal bleeding occurs on while the patient is already on therapy, in such patients, you may like to stop bevacizumab and just maintain on atezo, but outcomes are not clear. Why? Because this is clear, bevacizumab delays EVL ulcer healing and bleed control. After stopping bevacizumab, you can start within 1 or 2 weeks any invasive procedure, like you want to do tear, TACE or whatever, or you want to do paracentesis, it can be done. After 2 weeks, you can do an EVL after stopping bevacizumab. If somebody has undergone a resection, he can start bevacizumab after 4 weeks' time. Now, what is the effect of locoregional therapies? TACE, tear are likely to increase the HVPG, they increase the pressures in the sinusoids. Therefore, they have said a patient who is undergoing tear or TACE, LSM above 16 and SSM above 22 should be thought of, especially if they are undergoing surgery. There is no data on infiltrative HCC, and in my opinion, in them the EV's esophageal varices progress fast and can develop more acute variceal bleed. So look into infiltrative HCC beyond any criteria. Now, there is another group of patients who has portal vein thrombosis but has no invasion. Now, he was on anticoagulants and was on EVL. Now, such patients, anticoagulant oral DOACs should be stopped and low molecular weight heparin should be started. Beva should be stopped. Anticoagulation should continue. Even if the patient has bled, you continue low molecular weight heparin to prevent extension and monitor the patient's LSM and SSM. So this is my concluding slide. Assess portal hypertension in every patient with HCC and cirrhosis. Do endoscopy, monitor platelets and stiffness. If there is prevention of development of HCC, if you have good long-term vision, start your patients on non-selective beta blockers, whether PVT is there or not. Prophylaxis of variceal bleed or rebleed should be done, preferably by beta blockers. Acute bleed, EVL, add beta blockers. Rescue tips can be done, and surgeries can be done if the platelets are good and HVPG is low, else do tips. And immune checkpoint inhibitors can precipitate EVL ulcer bleed, delay healing, and then therefore stop bevacizumab. Thank you for your kind attention.
So it was as usual a masterly lecture. Any questions?
So do you think any role of anticoagulant for preventing portal vein thrombosis or long-term use of anticoagulants?
You mean tumor thrombus or non-tumor?
Non-tumor also.
Non-tumor, right now there is no data that you can prevent non-tumor thrombosis. Only we dissolve the existing tumor, non-tumor thrombosis. But I do think that if patient has 30% of non-tumor thrombosis and you dissolve it, it is better. So I do anticoagulant less than 50% also.
Yes. Sir, here also. Sir, SCC itself is a risk factor for rebleed. Yes. Portal vein thrombus further increases the risk of bleed. Yes. So when will go for tips in case of SCC PVT, the first bleed or the second bleed?
So, patient has bled and he has come to you. Should we do preemptive tips before the second bleed or not? I would certainly, that's a question I have not thought of, but I would try, if I have to go for SBRT or so, I would be very hesitant after a bleed. I would be very hesitant to give this patient TACE because he has bled already. Immune checkpoint can be given. I would preserve the tips for a rescue because his survival otherwise also is less than 6 months. So I will probably not do preemptive tips.
Thank you, sir.
Good question.
I have a theoretical question. So, bevacizumab maybe increase the risk of bleeding of varices, but do you think that it could be a treatment of portal hypertension if the patient received during 1 or 2 years bevacizumab because there is tumor response?
I was thinking when I was speaking that bevacizumab is not a devil. It actually can help the portal vein thrombus in one way or the other, but we need more studies to see if it downgrades the JAK2. I just share a small data. If we have 30 seconds, we did 200 patients of portal vein thrombosis with HCC. And JAK stat was induced in every single patient, not like Bhattacharya, but in them. So in my opinion, all portal vein thrombosis, tumorous thrombosis must get anticoagulant or inhibitors of JAK2. So bevacizumab may be helpful.
Thank you.
Sir, you said non-selective beta blockers improve the survival in HCC. So why this survival? Is it benefit simply on the portal hypertension or it has some effect on tumor? Number one. Number two, whatever we are giving the therapy for HCC, that means they should be combined for the management of decreasing the portal pressure also.
This is not in guidelines, but should be in guidelines. Non-selective beta blockers decrease translocation of bacteria. It also decreases risk of ascites because of reduced pressure, and it probably also helps in collateral formations and others. There can be one disadvantage. In portal vein thrombus, there is already reduced blood flow to the liver. Non-selective beta blockers may further reduce the blood flow. So child's A is okay, but child's B above 7 beta blockers may not be the best choice. Otherwise, it's good to use it.
Sir, any precaution for patients with high-risk varices who have already underwent EVL, who are planned to undergo a local regional therapy, maybe TACE, TEER, or even SBRT, should be taken before pushing this patient for such kind of therapies?
Very good question. I would recommend strongly that heart rate should come down to 55 to 60. Any one of you who takes such a patient who has already got EVL done, bring the heart rate to 55 or 60. If it does not come down, start Evabred, so the target heart rate comes down, and then you are safe.
So patient on bevacizumab, he is on treatment and he bleeds on esophageal bleed. So the endoscopy, the band ligation is to be delayed up for 2 weeks.
No, if somebody has bled on bevacizumab, I would say do an endo. If there is a post-EVL ulcer bleed, put a Danicella stent. If there is no, if it is the first bleed, then you can do band ligation and bevacizumab can be withheld for a few days. It should be okay. Like, you know, you do band ligation on anticoagulant, on aspirin, clopidogrel. So what is bevacizumab? Nothing more than that. One can easily do EVL on bevacizumab.
Sir, perfect talk. What is the interaction of lenvatinib or sorafenib with portal hypertension?
Sorafenib is anti-angiogenic, decreases portal pressure and is helpful. Lenvatinib also should do the same, but there is no data, at least to my knowledge, whether it reduces portal pressure. Sorafenib certainly helps in portal pressure reduction. Thank you.
So if there are none, so we can close this session. Thank you so much, sir, for actually, bringing up this untouched topic and educating us. Thank you again.
Thank you.
Thank you so much, sir, for the last session. Next session, we have big data and AI, computer vision and emerging technologies in liver tumor. So I request the chairpersons to come onto the dais. Dr. Vaishali Bhardwaj, HOD, Department of Gastroenterology and Hepatology, RML Hospital. Dr. Amitav Goswami, HOD of Gastroenterology in Medicity, Guwahati. And Dr. Harshvardhan Tewatia, Assistant Professor, ILBS. And the moderators, Dr. Praveen Sharma, Senior Consultant, Department of Gastro and Hepatology in Gangaram Hospital. Dr. Surender Singh, Assistant Professor, Department of Gastroenterology and Hepatology, SGPGI. And Dr. Pallavi Garg, Consultant, Department of Gastroenterology, M.I.C.E. Hospitals, New Delhi.
To call Dr. Dickman Verma to present AI models for HCC prediction, early detection and response for improving survival.
At the outset, I would like to thank the organizers, Professor Sareen, Dr. Ashok, and whole team of ILBS for giving me this opportunity. My job is to speak on artificial intelligence models for HCC prediction, early detection, and response to improve survival. Can we have the slides, please? So in brief, I'll be taking you through the unmet needs in HCC, what is AI and its potential in patients with HCC, several use cases of AI, and what lies in the future. We understand that HCC is the 5th most common cancer and 3rd most common cause of cancer-related mortality, and now the figure has changed to 2nd most common as stated by WHO. HCC is predominantly 90% of primary liver cancers. There is an increasing incidence of MASLD, MAFLD, and viral-related SCCs remain the most common cause yet today, although the incidence is decreasing. Unmet need in patients with HCC includes the early prediction, detection, and molecular characterization, and personalized treatment and prognostication. We understand that primary prevention of HCC is primarily based on detection of HCC before its occurrence, whereas the secondary prevention aims at early detection, molecular characterization, and the tertiary prevention aims at post-treatment outcome predictions and long-term survival outcomes predictions. Recently, NASL has tried to characterize the different stages of HCC and try to figure out different sub-stages amongst the BCLC B, C, and D, where subgroup of patients with BCLC B could be benefited through downstaging and liver transplantation. Whereas amongst patients with BCLC C, there are group of patients with portal vein thrombosis that can be benefited through SBRT and followed by systemic chemotherapy. Whereas in BCLC D, there are certain patients who are within UCSF and can respond to liver transplantation, and long-term outcomes at 5 years can be as good as patients within Milan criteria. It is basically the differences in the molecular characterization, their pathogenesis, that there are several staging systems, and this heterogeneity is unlikely to be captured by traditional algorithms which are based on logistic regression. There are several factors which govern the outcomes, patient's diagnosis, and prognostication, primarily related to tumor, its size, its shape, the liver functions, the expertise at a given center, and the availability of treatment modalities. Apart from these, socioeconomic factors, demographics, and explosion of emerging scientific literature, given the fact that there are so many factors that govern the patient's treatment and outcomes, it is practically impossible for any mathematical, statistical model to give a precise predictions. And as famous British scientist Bonks said that all models are wrong, some are useful. We need to identify that particular machine learning or any statistical model should be useful in day-to-day practice.
So basically, what is artificial intelligence and how it can help in patients with HCC? Artificial intelligence is nothing but making the computers to mimic human intelligence, that is to gather the data from various sources, assimilate that data, and give predictions that can be taken into account as an actionable item. We have seen an explosion of AI-related publications in hepatology. Per se for HCC, there are near about 861 publications as of date. Machine learning is a subtype of artificial intelligence which actually deals with mathematical algorithms that define or improve the prediction problems. And deep learning is a subset of machine learning which is based on architecture of neurons, which is inspired from the neuroanatomy of brain. These neurons in deep learning models have several layers. The input layer captures the data from either images, text, or structured data sets. The hidden layers processes that information, and these interconnected neurons have weights which is dependent upon the kind of weightage it gives to the predictors. And finally, there is an output layer which gives predictions depending upon the question in context. A typical workflow of deep learning model in patients with HCC would include imaging data sets from ultrasonography, CT, or histopathological images, combined with multimodal data sets of electronic health records and biomarkers, which is fed to computers through input layer of neurons. And depending upon the architecture of these neurons, there are different deep learning algorithms have been named. More importantly, the convolutional neural networks are the state-of-the-art machine learning, deep learning algorithms for processing such multimodal data. And the output is dependent upon the type of question in context. It can be diagnosis of HCC, prediction of therapeutic response, or prediction of survival on long term. A typical deep learning algorithm automatically extracts the information from images through input layer of neurons, whereas in machine learning algorithms, one has to manually extract the features and feed to computers. And then, according to the supervised or unsupervised learning, the machines can predict a particular area of interest, which is called segmentation problem, or the computers can predict presence or absence of HCC and differentiate it from benign other lesions in the liver. Or it can make up future predictions depending upon the question in context. AI models has to go through a life cycle of analysis, which starts with data collection, training of models, testing and validation of these models, followed by selection of a particular model which is performing the best, and deploying that model and looking at the impact of that model in a real world, followed by a randomized controlled trial. That actually completes the whole life cycle of AI. And the performance characteristics of a model is dependent upon the question in context. If it is a classification problem, the output of AI model in the terms of probability is plotted against presence or absence of a particular condition, and that can be seen as area under ROC curve or sensitivity, specificity, positive, negative predictive values, or F1 score or Matthews correlation coefficient. Typically, it breaks down to the whole process of AI-driven process into three key components. First is the data, which is given as an input to the computers, and primarily it is broken down to numerical or categorical variables which computers understand, followed by an algorithm which computers develop, and finally the output which is dependent upon the question in context, presence or absence as a classification problem. If we are trying to predict a particular numerical outcome, that is the number of days the patient is going to survive, it's the regression problem. Or in unsupervised clustering algorithms, it is the clustering of group of individuals, or dimension reduction in unsupervised clustering algorithms. There are several machine learning algorithms. One need not to understand each and everything, because one need to understand the application. As a clinician, we need to understand the application of machine learning algorithms in HCC. So there are several use cases. I'll tell you briefly what all is there in literature about AI models in HCC. There are several studies where applied on clinical data sets for prediction of HCC before its occurrence. That is the incident HCC. So decision trees are beautifully, performing over deep learning algorithms in structured data sets. And area under ROC curve can reach up to 96% for prediction of HCC. There are several AI-based algorithms which have been deployed on images, more so on CT and MR-based images, and ultrasound-based images, where the new technique, which is called texture analysis, has been introduced for making a diagnosis of HCC. And now there have been several algorithms for characterization of tumors, that is the grade, intermediate, high grade or low grade, depending upon the pathological image. A recent study published in JHEP showed that state-of-the-art CLAM model could predict the T-cell exhaustion and the several gene signatures in patients with HCC. There are several biomarker-based studies, and biomarkers were ranging from transcriptomics to miRNA to metabolomics, and the epigenomics, which is the methylation amongst the histopathological images of HCC. And the model which could predict the outcomes or long-term outcomes of patients with HCC. There are several studies where AI models have been used to segment HCC amongst the CT images, classify the HCC and differentiate it from nodular lesions. This was a very interesting study published in 2019 where second harmonic generation microscopy was employed on histopathological images to automatically label the diagnosis of HCC through convolutional neural networks. There are several AI-based studies where AI models have been used to predict the future or the temporal outcomes amongst the histopathological images of HCC. There are several studies in liver transplant related outcomes, and most importantly, this review published in 2023 showed that pre-transplant waitlist mortality, during transplant, one could predict the presence of steatosis, one could predict the post-transplant graft survival and patient survival through artificial intelligence. So I'll be skipping through the details of deep learning algorithms, but one thing is very, very important, that prediction of HCC recurrence post-liver transplantation could be identified through artificial intelligence on liver biopsy specimens, and presence of stoma, cytological atypia, nuclear hyperkinesia, and immune cell infiltration could predict the recurrence of HCC post-liver transplant. AI and virtual reality could also be used for planning the resection and liver transplantation, and 3D bioprinting and mixed reality is an upcoming area one could predict and guide the surgeries using artificial intelligence. The future lies in multimodal data and integration of that data through deep learning algorithms, and one is moving towards personalized medicine for treatment of HCC. And AI is guiding us through the patient journey for improved outcomes. And finally, future of AI is to early adjust the treatment of patients, treatment through use of deep learning algorithms. One could predict that what type of therapy can be useful in a given patient, or early adjustment of therapy using deep learning algorithms. So friends, the take-home message from this talk is that artificial intelligence is helping us in guiding the management of patients, early detection of patients with HCC, prediction of their long-term outcomes, and the molecular signatures through histopathological images and CT-guided images. Thank you very much.
Excellent talk, Dr. Nipun. So just any questions from the audience?
Nipun, I'd like to take a question. So do you think AI with deep learning and machine learning help in screening? Screening will be an important thing in the future.
So yes, So any deep learning or machine learning algorithm has to pass through a stage of, deployment and real world application. So there are at least 6 different algorithms which have been demonstrated in cirrhotic patients, hepatitis B patients, to predict the incident HCC, and with the area under ROC curve reaching up to 0.96. But the problem is we lack studies in patients with NAFLD, alcoholic liver disease. And it needs to be tested in a randomized controlled trial to be proven as a cost-effective approach before we deploy a particular machine learning algorithm.
Yes.
Hi, Nipun. Excellent talk as always. Thank you so much. So I had 2 questions. Firstly was regarding the 6 gene signature that you talked about. Now, to my mind, this is actually a throwback to previous statistical models where we used to come out with, regression and then come out with 6 endpoints that we were correlating with. Isn't a 6 gene signature a bit reductionist when you talk about an AI model? Because the beauty of an AI model is you'll be able to combine numerous variables and perhaps incorporate interactions that you were not accounting for before.
So this brings to the concept of accuracy and the interpretability of machine learning models. So, the computer science and machine learning algorithms are designed to be accurate, whereas medical science is looking for interpretability. So whenever we try to develop a machine learning algorithm, it is on the large number of features. It is more accurate. But ultimately, once you bring down that to the interpretability component of AI, one has to go to a reductionist approach to actually find out what are the top 5 features or top 6 features which are actually defining that outcome. So therefore, this is a conflict between the highly accuracy of a given machine learning model and the interpretability. So as a medical scientist, as a physician, we are always looking for the top features. So therefore, machine learning algorithm which was developed in that study, taken from TCGA dataset and validated on Henry Mondor Canadian dataset, was actually looking at large number of features through histopathological images to predict gene signatures. But ultimately it boils down to what all features which are predicting that those gene signatures. So I think I have given your...
Sure. The second point was that of all the questions that you, the studies that you quoted, how many of them have gone on to have prospective real world validation?
No, none of it. None of it today. So we have 800 plus studies, but I would say we need more prospective. So I overskipped that one slide. There is a systematic review of all the studies on HCC, and there they showed that the index test, that is the deep learning algorithm or the machine learning algorithm, had a high risk of bias because of limited derivation sets, lack of validation sets, and single center studies. So we need more large data set with multicentric studies and impact assessment through randomized controlled trials before we deploy those machines in a real world.
Sure. Thank you so much.
One last question.
Yeah, just a short question about artificial intelligence and imaging. Do you think that it will be easy to do artificial intelligence on MRI? Because CT scan, you have arterial phase, venous phase, it's easy, but MRI, you have a lot of different sequences, and the quality of MRI is could be heterogeneous. So for CT scan, but for MRI, any data about the ability to do artificial intelligence on that?
Well, very nice question. So basically, imaging out of CT, MRI, ultrasound or ultrasound Doppler, many studies have shown that you can reach an accuracy up to 90%. But given the fact that MRI has so many sequences, more so this radiomics which has come up, and different features of radiomics can identify a particular tumor and its long-term outcomes which a naked eye cannot see in a particular image. So I completely agree, but I think it is the integration of data apart from imaging, the clinical data, the biological data, the patient's treatment, and the socio-demographic factors, the availability and the center expertise, and cross-ethnic, cross-multidimensional data. It has to go through into the deep learning algorithms for giving the outcome.
Agree with you. We need a lot of patience to do that,
yes,
to have a good model.
Right. So one last question, Dr. Nipun. has there been any study looking at the response to therapy using AI-based models for HCC?
Yes, yes. There are a lot of studies, not only for immunotherapy, also for, taste, tear, microwave ablation, radiofrequency ablation. There are a lot of numerous studies, everyone from single center. So, you need to have a larger data sets, and it is just, we are in an infancy phase for AI models in HCC, I would say that.
Thank you so much, Dr. Nipun. Thank you.
Thank you.
So the next talk is going to be delivered by Dr. Mamta Bhatt, who is an hepatologist and co-lead of Transplant AI Initiative at Ajmera Transplant Program. She's an associate professor in the Department of Medicine, University of Toronto, Canada, and she'll be joining us online.
Hello, everyone. Thank you so much to Dr. Sarin and Dr. Chowdhury, as well as the organizing committee for the kind invitation to present at this wonderful forum. I see really, tremendous talks having been given in the last few days. So really, congratulations on this excellent forum. As mentioned, I'll be speaking about AI and basic research for liver cancer, target pathway, and drug discovery. I lead a translational research program dedicated to improving outcomes of liver transplantation, particularly for patients with HCC and MASLD. And certainly, we now have experience in both developing as well as deploying machine learning tools into the clinical setting. And so it's on the basis of this interdisciplinary experience that I will be giving this talk today. These are my disclosures. So this is the outline of my talk. As Nipun, Dr. Verma, very nicely described, certainly HCC has complex biological heterogeneity. And, clearly one size doesn't fit all. I will also provide an example in my own research of machine learning tools applied to omics data in HCC, as well as finally conclude with some visions for the future for personalized therapy with AI tools. And I think it's really important to recognize, as Nipun nicely said, there's lots of data that's being generated, and certainly from across the spectrum, whether it's clinical data or in terms of in vivo modeling, the types of omics data generated through in vivo models, there is this potential to, say, apply these advanced tools to analyzing these data. So clearly, as I said, AI in HCC has significant potential given that one size doesn't fit all. Hepatocellular carcinoma, as you all know, arises in the setting of various chronic liver diseases. And there is this ongoing cycle of compensatory regeneration over the many years of inflammation, injury caused by different etiologies of chronic liver disease. And HCC most commonly arises in the setting of cirrhosis. As you know, this is a high fatality cancer still, and this is for various reasons, as you would have heard in the last 2 days. But I think it's important to consider that there is a great deal of heterogeneity and complexity by virtue of these different chronic liver diseases in the setting of which HCC develops, as well as the fact that HCC most often develops in the setting of established cirrhosis. And so there are these different considerations that need to be accounted for when considering a patient. Now, in terms of hepatitis B associated HCC, you have this non-cirrhotic pathway where the hepatitis B virus is able to directly integrate into the host genome randomly proximal to a proto-oncogene, but there's also, say, direct mechanisms by which this can induce HCC. The most common pathway to HCC, however, lies in the cirrhotic pathway to HCC, as I mentioned, where you have many years of inflammation and oxidative stress with hepatocellular necrosis. fibrosis, cirrhosis, and over time, given this compensatory regeneration, there is this potential to accumulate driver mutations that ultimately lead to dysplasia and HCC. And so, as Dr. Verma mentioned, the TCGA, so the Cancer Genome Atlas, really gave us a sense as to the biological complexity of HCC, and certainly there have been subsequent studies really highlighting the great deal of molecular heterogeneity and complexity in HCC. Several pathways are of note here, but there are certain ones that really jump out, including the Wnt beta-catenin, Ras-RAF-MAP kinase, mTOR, sonic Hedgehog pathways. So there are various pathways that are differentially upregulated in the setting of HCC, and so clearly not suited to a one-size-fits-all approach. Now, if one looks at the management of HCC, clearly the BCLC guidelines are pivotal for directing and informing the management of HCC, and this is really considering both the HCC stage as well as the presence of concomitant liver dysfunction. And so, this is the very unique aspect of HCC, which one doesn't consider in the setting of other cancers. So clearly with HCC, one has to really take into consideration the underlying liver disease on the basis of which HCC has developed. So we are left with, I think, two very important problems. One is that HCC develops in the setting of these various chronic liver diseases and evolves over time from dysplasia to HCC. And then secondly, you have the fact that this is arising in the setting of most of the time cirrhosis, where there is concern for the ability of a patient to manage and tolerate therapy due to impaired liver function and drug metabolism. So these are very unique considerations to HCC. Now, as Dr. Verma was mentioning, I think he really set the stage for my talk. There's so much diversity of data that we are generating, and certainly with the amount of data that is being generated, there's a lot of potential. So certainly there's imaging data, pathology data, clinical and laboratory tests, various say response to therapy. So there is that potential to really examine over time, with techniques such as reinforcement learning, really understanding, how one reacts to those responses to therapy to then redirect management. And then beyond that, omics data certainly is going to be individual to a given tumor. And you have this plethora of various types of data: genomics, transcriptomics, proteomics, epigenomics, T-cell receptor sequencing. All of these data can be generated if we biopsy these lesions. Now, the current standard is to have radiological diagnosis on the basis of which HCC patients are managed, but certainly I think given this complexity, I think there is a certain interest, certainly, to biopsy these lesions in order to be more personalized in the approach to these patients. Now, this is the landscape of what has been done so far, and I would say, it's still pretty much in a nascent phase. This is a review that was published last year, as you can see below, and my group also had summarized the landscape of AI in terms of diagnostic and prognostic molecular biomarkers for HCC. And at this point, it's certainly quite limited and has been limited to publicly available data sets, and I would highlight this one at the top, which was published in Frontiers in Genetics in 2020. This is actually from IIIT Delhi, and basically they looked at publicly available data sets. I'll get into a bit more detail about this particular study. There are various other smaller scale studies that have examined different biomarkers and applied different machine learning tools, as you can see here, in order to predict good versus poor prognosis as a result of resection of HCCs. So this is, the first study that I mentioned earlier. So this is the IIIT study, wherein they looked at large-scale transcriptomic data from the GEO as well as TCGA. There were 36 data sets. They pre-processed these data sets, which actually arose from different profiling techniques. So that is certainly an issue in order to kind of calibrate and bring together these different data sets. Ultimately, they examined different potential machine learning models on 27 overlapping genes among these data sets, then look at their prognostic value, and they isolated in the end 5 prognostic genes that were then evaluated on 4 external validation sets, looking at overall survival, progression-free survival, disease-specific, and disease-free survival.
I'm sorry,
So
Dr. Mamta,
were,
but we're a little short on time, so we can just quickly go through the presentation.
Okay, sure. No problem. I think, overall, this really shows the potential for these different machine learning models, including k-nearest neighbors, random forest, to predict prognosis in HCC. I think for the sake of time, given the limitations, I will skip over this, which is an example of a study that we have performed in my research program. And then I'll conclude basically by saying that there's, I think, a great deal of potential for personalized therapy. Certainly lots of work going on in drug design, chemical synthesis, formulation. With AlphaFold, the onset of AlphaFold by Demis Hassabis and John Jumper, there's this great ability to now predict 3D structure of target proteins based on sequences, proteomic data, to then predict the actual conformation of a protein, and then on the basis of that, determine what might be the optimal compounds for that particular protein, and then evaluate and validate these compounds in the setting of HCC, both in vitro and in vivo, and ultimately in PDX models. I'd also like to highlight that we are currently working on an RNAi therapy that has the ability for dose titration based on liver function. We have a fluorescent labeled RNAi particle, nanoparticle that simulates HDL to deliver very specifically to liver cancer cells RNAi therapy. So I think in the end, I'll conclude by saying that my sense is that we will, in the long term, be using AI as a co-pilot in HCC diagnosis and management. This is looking into the future. I think there is this tremendous ability to integrate different types of data to inform personalized predictions for patients with HCC in the long term. So thanks very much, and happy to take questions.
Yeah, excellent talk, Dr. Mamta. So I have a couple of questions. So first question is, as you mentioned that there is a lot of variation in how AI data is being reported. So are we working in the direction of making some consensus guidelines so as to how the AI data is to be reported, so that we have some sort of consensus and we can compare different data sets? And second question is, how far we are from using these AI models in our day-to-day practice? Thank you.
So are you referring to AI applied to omics data specifically in terms of consensus around that? I'm not aware of any, say, large-scale, global efforts in that regard, say, across the spectrum of cancer. But I think, certainly the American Association for Cancer Research and other such organizations, I'm sure, are looking in that direction. Certainly there's a lot of interest, particularly in the cancer world, to integrate diverse types of data. So I think it's a great question. I'm not aware of any such global or national, international efforts, but I think In terms of the clinical world, certainly, I would say there are a number of, say, FDA-approved applications, radiology and pathology-based software tools that are now already deployed into clinical practice in the U.S. And I think, you know, a lot of us are now integrating these tools into our clinical workflows. So I think bringing together omics data isn't so much of a stretch to then really personalize the care of patients.
So due to lack of time, we're concluding it here. We are concluding the session. The final talk is by... so it's a recorded talk, Radionomics and ICC, How Accurate is the Diagnosis, Therapy and Response by Professor Ziolong Q, Zhonganda Hospital, Southeast University, China. So we can play on the recorded talk.
Hello, everyone. My name is Xiaolong Qi from the Zhongda Hospital of the South University of China. It is my great honor to attend today's ILCC conference, and I would like to share this topic about the radiomics. Where are we? In recent years, more and more researchers have been carried out to explore the application value of radiology in the diagnosis and treatment of liver disease, which extend the guide value of radiology in the clinical practice for liver disease, especially for the hepatocellular carcinoma. Today, I will introduce the radiomics and liver disease in three parts. How accurate is the diagnosis and therapy response? What is radiomics? Why we use radiomics, and how we use radiomics. And the first part, what is radiomics? Initially, some studies hypothesized that through the quantitative analysis of a medical image data, phenotype, and genome protein biomarkers, and even prognostic informations can be inferred. With a great deal of radiomic studies being considered using multi-parameters and multi-modality imaging in terms of liver disease diagnosis and treatment decision making. In certain scenarios, this artificial intelligence-based technique could even compete pathologic golden standard, providing new ways for unsolved clinical problems in the paradigm of liver disease management. Here we review the basic concepts of radiomics methodologies specific for liver studies from data acquisition, liver lesion segmentation, feature design to model construction, and talk about its applications. And why we use radiomics. Hepatocellular carcinoma, HCC, is the most common primary liver tumor, and its global incidence rate is still rising. And radiomics plays an important role in the detection, differential diagnosis, biologic behavior prediction, efficacy prediction, and the prognostic evaluation for the HCC. Interest in both CAD and radiomics, two terms that are occasionally used interchangeable, has increased sustainable within the past 2 decades. A PubMed search for the CAD, or the computer-aided diagnosis, or radiomics and cancer tumors and tumors, over 44,000 publications since 1967. Over 85% of which are from 2004 onwards. Radiographic assessment of disease most commonly rely upon visual evaluations the interpretations of which may be augmented by advanced computational analysis. In particular, artificial intelligence is promised to make great studies in the quantitative interpretation of cancer imaging by experts, clinicians, including volumetric delineation of tumors over time, extrapolation of tumor genotype, and the biology cause from its radiographic phenotype. Prediction of clinical outcome and assessment of the impact of a disease and treatment on agent augurs. And next part, how we use radiomics. This part will focus on the work on radiomics of the liver disease and to demonstrate its clinical application. For preoperative prediction of a macrovascular invasion, we call MVI, in hepatocellular carcinoma, Dr. Yang developed and validated a radiomics nomogram for preoperative prediction of MVI in HCC. The nomogram based on the model exhibited a C-index of 0.9 and 0.86 in the training and validation cohort, and fitting well in calibration curves. And decision curve analysis further confirmed the clinical usefulness of the nomogram. The results demonstrate that the nomogram, which incorporating clinical radiology risk factors and the radiology features derived from images, achieved satisfactory preoperative prediction of the individual risk of MVI in patients with hepatocellular carcinoma. Since the liver image reporting and data system called the LIRADS initial release in 2011, it has evolved and expanded in scope. It starts as a single algorithm for hepatocellular carcinoma diagnosis with CT and MRI with extracellular contrast agent modalities and context of use. Furthermore, it has developed in its long lesions, report templates, and supplementary materials. For example, Dr. Xia developed a radiomics approach for predict MVI status based on the preoperative multi-phase CT images to identify the MVI-associated differential expressed genes. The model used a novel multi-algorithm network covering image registration and sealbed, VOI outlining, imageomics features extraction, calculation, de-reduction, dimensionation reduction modeling, and modeling validation, prognostic stratification of models, and potential biologic mechanisms. Besides, our team is still increasing an automated system that predicts the accuracy of MVI in individuals of liver cancer using dynamic CT images. This study employs the deep learning technologies to segment liver tumors in the CT images accurately. Then, the radiomics features of peri-tumor, intra-tumor, and subtraction images were extracted, which we quantified data to characterize the characteristics of the tumor. And these features provide detailed information about the tumor's composition, shape, texture, surrounding environment, and dynamic change. HCC exhibits strong inter-tumor heterogeneity with different biologic characteristics closely associated with prognosis. And Dr. Gu invested in the performance of MRI-based radiomics signatures in identifying GPC3 positive HCC. The combined nomogram integrating independent clinical risk factors, AFP, and the radiomics signature showed improved calibration and prominent predictive performance of AUC like 0.9 and 0.9 in booster training and validation cohorts, respectively. The proposed MRI-based radiomics signatures is strongly related to JP3 positive, and the combined nomogram incorporating AFP and radiomics signatures may provide the effective tool for non-invasive and individualized prediction of GPC3 positive HCC. One, predict the expression of CK19 in patients with HCC before operation, and then he screen high-risk patients with HCC. Multi-sequence images and clinical data of 227 patients with hepatocellular carcinoma also reduced the dimensionality of the image features, and the largest model fused multiple sequence tags. The prediction accuracy of CK19 can reach 0.85. Distinct vascular patients, including MVI and VETC, are associated with poor outcomes for patients with hepatocellular carcinoma. And this study by Dr. Men identified an image-based surrogates of distinct value patterns embed accurate prediction of RFS. It can potentially be used to identify the HCC surgical candidates who may benefit from automatic resection. And Dr. Men explored the effect of predictive MVI on early recurrence after automatic resection and non-automatic resection to assist surgical strategies. And the prediction models incorporating radiomics provided an accurate preoperative estimation of MVI, showing the potential for choosing the more appropriate surgical procedures between AR and NAR. Patients with HCC receiving TACE and intervention the methods have various clinical outcomes. And Dr. Men developed a radiomics signature from a pre-treatment CT to establish a combined radiomics clinic models to predict the survival for these patients. And the CT radiomics signature represents independent biomarkers of survival in patients with HCC ongoing TACE. And the CRC model displayed improved the predict performance. And Dr. Fu proposed an individualized model predict PFS, the follow-up data, difference between IR and TACE to assist the optimal treatment choice. And the model included treatment age, sex, modified BCRC stage, fusion lesions, hepatocellular carcinoma capsule, and 3 radiomics features. With good discrimination and the calibration, on the curve for 3 years PFS was 0.8 in the training data set and 0.7 in the validation data set. Similar results were achieved in 1 and 2 year PFS. Our team is also developing predictive model by integrating clinical parameters, MRI features, and 1 month treatment response to predict the 6 months response of HCC after TACE. This figure demonstrated the performance of radiomics, the red radiomics, and TR-trace models, a model based on the treatment response at 1 month radiomics signature and cochlear enhancement. Except for HCC, our team also explored the risk stratification of cirrhosis and portal hypertension. And CSPH is associated with an incremental risk of esophagus varices and overt clinical decompensation. However, HVPG measurement, the golden standard for defining CSPH, is invasive and not suitable for routine clinical practice. We identified a radiometric signature, an accurate model for non-invasive detection of a CSPH in a cirrhosis. And the tool we call the R-HVPG, radiometric HVPG, can facilitate the identification of CSPH rapidly when invasive TIPS transjugular procedure is not available. Meanwhile, we investigated the ability of deep CNN, convolutional neural network analysis of a CT, MRI, to identify the patient with CSPH. The CT-based CNN analysis identified the patient with CSPH with an AUC value of 0.9 in the training and with an AUC of 0.9 in the validation sets. And the MRI-based CNN analysis identified the patients with CSPH with AUC of 0.99 in the training and the AUC of 0.92 in the validation sets. And this provides a non-invasive and rapid methods from detection of CSPH. We also developed auto machine learning CT radiomics HVPG quantitative models we call the A-HVPG. And then we validated the model in the internal and external test sets by the AUC for HVPG different stages, which means HVPG less than 10, 10 to 12, 12 to 16, 16 to 20, and more than 20. And compare the model with imaging and serum-based tools. And the final A-HVPG models achieved AUC over 0.8 and outperforms other non-invasive tools for assessing HVPG. And the model showed performance improvements in identifying the severity of portal hypertension, which may help non-invasive HVPG primary prophylaxis with HVPG measurement are not available. And very recently, we investigated a vascular geometry model on the non-invasive diagnosis of CSPH, also based on the machine learning methods. And a variety of vascular parameters were extracted from the portal vein, hepatic vein, outer and inferior venous cover, and then entered into vascular geometry models for identification of a CSPH. And the contrast enhanced the CT and MRI-based models performed well in the test set with AUC 0.9, external test sites with the AUC of 0.84 with good diagnostic consistency for hepatic venous pressure gradient measurement. And ladies and gentlemen, to date, most studies evaluating AI and radiomics applications have not been well validated for reproducibility and generability. And the results to highlight increasing concern efforts in pushing radiomics technology to clinical use and to impact the future in care. All of the above the work and the part of the results come from the CHAS colleagues. So I would like to thank my team in the CHAS and the CHAS colleagues, which including multidisciplinary teams, including hepatologists, gastroenterologists, radiologists, pathologists, etc. And we work together for advancing the technology and clinical practice for the liver disease, especially for the cirrhosis and hepatocellular carcinoma. And during the past 7 years, we conducted more than 30 clinical multi-center trials and achieved a couple of results. And we do believe the radiomics and some other artificial intelligence technologies can help the hepatologist to advance the patient care. Thank you very much for your time.
So with this, we conclude this session, and we would like to thank all the speakers for such informative talks. Thank you.
We thank the chairpersons, the moderators and the speakers. Now we come to our concluding keynote lecture, Therapeutic Radiological Interventions for Cholangiocarcinoma and Non-HCC Tumors. May I please call upon the chairpersons, Brigadier Chandra Mohan, Department of Radiology, HGT Medical College, Gurugram, Dr. Vikas Yadav, Professor of Radiation Oncology, Safdarjung Hospital, New Delhi, Dr. Abhishek Bansal, Senior Consultant, Shri Action Balaji Hospital, Dr. Babulal Meena, Assistant Professor, Institute of Liver and Biliary Sciences, and Dr. Chandan Pal, Assistant Professor, Radio Diagnosis, UCMS, New Delhi.
Now, the next speaker will be Dr. Sanjeev Kalwa. He is Chief Division of Intervention Radiology, Department of Radiology, Massachusetts General Hospital, Harvard University, Boston. He will deliver talk on the therapeutic radiological intervention for cholangiocarcinoma and non-HCC tumors. So please start, sir.
Good evening, everyone. I hope you can hear me now. At the outset, I would like to thank Dr. Sarin and Dr. Amar Mukund and the entire team of the organizers for allowing me to participate in this international liver cancer course. I will discuss various interventional radiological therapies, the current evidence, and outcomes in the treatment of cholangiocarcinoma and neuroendocrine tumors. Given the time constraints, I excluded colorectal metastases from this talk. The interventional radiological therapies to treat liver cancer can be grossly divided into two types: percutaneous ablation and transarterial therapies. Ablative therapies use thermal, chemical, or electrical energy. Transarterial therapies use bland particles causing ischemic injury or particles that deliver chemotherapy or radiation to the tumor. Thermal ablation involves percutaneously placing an ablation probe into the tumor under ultrasound or CT or MRI guidance. Depending on the type of the ablative technique, thermal energy is delivered, causing coagulative necrosis of the tumor. What lesions are ideal for ablation? Lesions that are 3 centimeters or smaller have the best outcomes with more than 95% complete response to ablation. Though one can technically treat any number of lesions, treating more than 3 lesions is challenging. Peripheral lesions are safe to treat. However, lesions near the central bile ducts or in the subcapsular location can risk injury to the bile ducts and the dome of the diaphragm. Having expertise improves outcomes and allows to treat complex and difficult to reach lesions. Compared to surgery, ablation is less expensive, easy to perform, and is associated with a low rate of complications and reduced hospital stay. Irreversible electroporation and pulse electric field systems disrupt the cellular membrane and destroy the tumors. These are effective against lesions that are 2 centimeters or small in diameter. These are specifically useful for lesions that are central in location and not amenable for thermal ablation, as this energy does not destroy bile ducts or blood vessels. Transarterial therapies are based on the fact that the hepatic artery supplies the tumors, and tumors have high vascularity compared to normal liver. So intra-arterial infusion of drugs and embolic materials would reach these tumors and lead to tumoral necrosis. Transarterial therapies are usually applied for hypervascular, multifocal, and large lesions that are not amenable for ablation. Portal vein thrombosis portends a poor prognosis, but a segmental or lobar portal vein thrombosis is not a contraindication for treatment. Patients with a preserved liver function, good performance status, and no extrahepatic disease are the best suited for transarterial therapies. Bland embolization uses 100 to 300 microns or larger particles that are injected into the arteries supplying the tumors. And this results in ischemic tumor necrosis. This is commonly used in neuroendocrine tumor metastasis. In conventional chemoembolization, doxorubicin, mitomycin, and cisplatin are mixed with lipoidal and injected into the tumor-feeding arteries, followed by either gel foam or particles, resulting in ischemic tumor necrosis and cytotoxic cellular injury. This is commonly used for HCC, cholangio, and metastasis. Drug-eluting beads chemoembolization uses the drug-loading feature of the new particles, and these are injected into the tumor-feeding arteries, resulting in cytotoxic and ischemic tumor injury. Radioembolization employs small resin or glass microspheres loaded with yttrium-90, which emits beta radiation and destroys the tumors. Let us discuss about cholangiocarcinoma. Cholangiocarcinoma is an uncommon cancer that arises from the bile duct epithelium. There are three types. The intrahepatic type is the least common, but is the one that is most amenable for interventional therapies. The incidence of intrahepatic cholangiocarcinoma is rising and is predisposed by biliary cirrhosis, primary sclerosing cholangitis, choledochal cyst, and parasitic biliary infestations. It presents as an incidental liver mass or abdominal pain or weight loss. Imaging shows a PET avid mass or a periductal or intraductal mass. PET also helps detect occult metastasis. Staging laparoscopy has still a role, as it is the most sensitive test detecting peritoneal metastasis in this patient population. Surgery remains the only curative option with a 5-year survival of 14% to 40%. However, only 15% of these patients are eligible for surgery at the time of the presentation. Untreated unresectable cholangio has a median survival of 5 to 8 months. Gemcitabine and cisplatin combination therapy has improved survival to 12 months. Newer therapies, including Abraxane, FGFR inhibitors, and immunotherapy drugs such as pembrolizumab are being used in clinical trials now. One study has shown that combining intra-arterial infusion of 5-FU with systemic chemotherapy improves survival and conversion to resection. Radiation is often combined with surgery or systemic chemotherapy for improved survival. Let us talk about ablation for cholangiocarcinoma. This is an example where microwave ablation is used to treat a left lobe liver lesion in a non-surgical candidate. Post-ablation image shows complete response with no residual lesion. In cholangiocarcinoma, thermal ablation is considered when the tumor is unresectable or when the patient is not a surgical candidate, or if there is a residual or recurrent disease following surgery or other therapies, and in combination with systemic chemotherapy to improve immune response to tumors. In a meta-analysis of 20 studies comprising 917 patients, the technical efficacy of ablation was 92%, with a major complication rate of 6%. The 1, 3, and 5-year survival was 81%, 41%, and 23% for primary lesions, and slightly less for recurrent lesions. The recurrent-free survival was 40%, 22%, and 19%, whereas the percent without local tumor progression was 79%, 60%, and 58%. The technical outcomes of radiofrequency ablation ranged widely from 66% to 96% and quietly dependent on the tumor size. On the other hand, the technical effectiveness of microwave ablation was superior at 91% to 92%. Poor survival following ablation is associated with old age, large tumor size, recurrent tumor, and use of radiofrequency ablation as opposed to microwave ablation. For larger lesions, one could consider a combination of microwave ablation and chemoembolization with an acceptable results of 70% 1 year and 60% 2-year survival. As mentioned before, intra-arterial therapies are indicated in unresectable, non-ablatable tumors, single or multifocal disease in patients with a preserved liver function and good functional status. One could also consider radiation segmentectomy in small lesions that are not amenable for microwave ablation. This is a case of a 2.5 centimeter cholangiocarcinoma that is high near the dome of the diaphragm that was treated successfully with Y90 glass microspheres. The cone beam series demonstrating the enhancement of the tumor on the CT. This is post Y90. There is a progressive reduction in the lesion size with a durable response even after 10 months' time. In a meta-analysis of 21 studies comprising 921 patients, Y90 treatment downstaged disease to surgery in 11%, and the overall median survival was 12.7 months. One study compared DEP TACE with conventional TACE. The time to disease progression was similar with either treatment, but there was improved overall survival with the DEP TACE compared to conventional TACE. However, our study, comprising 198 patients, showed no significant difference in overall survival, whether a bland embolization or chemoembolization or Y90 was used for intrahepatic cholangiocarcinoma. All types of intra-arterial therapies are well tolerated with a low incidence of grade 3 or grade 4 toxicities. One study indirectly compared outcomes of hepatic arterial infusion chemotherapy plus systemic chemotherapy with those of intra-arterial therapies and reported superior outcomes with hepatic arterial infusion chemotherapy plus systemic chemotherapy. However, the data is very limited and further studies are required to confirm these findings. In conclusion, intrahepatic cholangiocarcinoma is a rare tumor. Data support use of loco-regional therapies for inoperable and recurrent disease. While transarterial therapies are equivalent, there is a need to assess the role of combination therapies, especially with immunotherapy. Let us move on to neuroendocrine tumor liver metastasis. Neuroendocrine tumors derive from embryonic neural crest tissue, most originating from GI tract or pancreas. 20% of the patients have metastasis at the time of clinical presentation, and 40% develop metastasis during follow-up. The survival depends on the age, sex, primary tumor site, stage, pathological differentiation, histological grade, and presence of metastasis. Liver metastases are the most common metastasis in these patients. The liver is the only site in 50% of these patients. The prognosis depends on the tumor volume. IR therapies are applied for symptomatic patients and in patients with tumor progression despite systemic chemotherapy. Poor survival is associated with pancreatic primary, high Ki67, non-dissection of primary tumors, more than 50% liver involvement, and poor performance and hypovascular tumors. Both bland embolization and chemoembolization provide similar outcomes. There is a trend towards greater response to bland embolization for GI primary, whereas chemoembolization is better for pancreatic primary. Bland embolization is better tolerated with a low rate of complications compared to chemoembolization. Conventional chemoembolization is superior to DEP TACE, as DEP TACE was most commonly associated with high incidence of biliary complications. This is an example of a patient with symptomatic metastatic insulinomas. The CT scan shows large hypervascular tumors, and that was treated with bland embolization, starting with the left lobe first. Subsequently, we treated the right lobe. And the post-embolization CT scan obtained 2 years after demonstrates excellent outcome with significant reduction and necrosis of all the tumors, and patient became asymptomatic just with 2 treatments of bland embolization in this patient. So both bland embolization and chemoembolization successfully improve symptoms in these patients from 60% to 90%. The overall survival is quite variable depending on the tumor size and ranges from 1 year to 7 years. Y90 radioembolization is also very helpful in treating neuroendocrine liver metastasis. This is an example of Y90 treatment of a large right lobe lesion with a partial response to post-treatment. 2 recent meta-analyses, including 19 and 11 retrospective studies of more than 800 patients, reported a median survival of 28 months and 32 months, with an 88% disease control rate following Y90 radioembolization. A superior response was observed if the tumor received more than 191 grade to the tumor. And if you have less than 70 degree, there was no response. So this is very useful whenever you plan Y90 for this patient population. One systematic review compared the outcomes of Y90, bland embolization, and chemoembolization and showed no significant difference in survival outcomes. In conclusion, embolization for neuroendocrine liver metastasis is considered for symptomatic and progressive disease. Given the equivalent outcomes of bland embolization, chemoembolization, and Y90 radioembolization, it may be prudent to start with the bland embolization as it is well tolerated and keeps the option of future Lutathera therapy for these patients. Thank you. Happy to take questions.
Thank you, sir, for a nice presentation. One question from my side is, what is the most common drug used in the intra-arterial chemoembolization for the cholangiocarcinoma? And what is the dose of that drug? Most commonly used.
So right now, we do not do in our place conventional chemoembolization for cholangio. If we were to use, we still stick with the same doses of doxy, mitomycin, and cisplatin. When we use doxorubicin, we have tried both, when we were doing drug-eluting bead chemoembolization, we tried both doxorubicin and irinotecan for these patients. We try first with doxorubicin only. If the patient did not respond, we have switched over to irinotecan. But at present, in our department, we do not use any chemoembolization. We always do only Y90 for all these patients. Chemoembolization is used only if there is recurrence following Y90 radioembolization.
Okay, sir.
Do you have any experience on high dose rate brachytherapy, particularly transluminal in cholangiocarcinoma?
That's a great question. So I was part of the trial in the University of Texas Southwestern where we did try to place brachytherapy device into the tumor through a sheath placed into the intraductal tumor location. It is very cumbersome, but we have done it. But it was limited to 1 or 2 trial patients only. Yeah, you can do it, but experience is limited.
Yeah, thank you, Dr. Sanjeeva, for an excellent talk. Just 2 things I want to know. We were thinking of doing HIFU in cholangiocarcinomas and also for laser. So what is the current status on these 2 modalities?
Unfortunately, I have no personal experience with HIFU in liver tumors. One of the problems with treating liver tumors with the HIFU is that there is a movement of the liver with the respirations. So focusing the HIFU on the tumor could be problematic, but there are methods to reduce that. So I think we had to try and trial them and see how it responds. There may be size limitations as well. There is a recent device that is coming, just approved last week by FDA. It is called histotripsy, and which uses ultrasound only, but not a HIFU method, but it's a slightly different technology, and which can destroy these tumors, and is also associated with a very high immune response with this therapy. So it may be coming very soon to India as well. I have no personal experience with the laser. In the US, we don't use laser therapies to liver. I think Europeans use laser quite a bit, and they may be better people to explain how they work.
Okay, thank you.
Dr. Bajal, sir.
Hi Sanjeeva, Sanjay Bajal here. Thank you for that lecture. Just wanted to get your thoughts on where do you place intra-arterial PRRT for neuroendocrine liver metastasis?
Great question. So the whole concept of PRRT is based on targeting the tumor through ligand-based approach. So when you can target the tumor based on the chemical composition of the tumor itself or membrane antigens, I'm not very sure what is the advantage of intra-arterial delivery. But having said that, intra-arterial Lutathera could be considered. I think Cleveland Clinic is doing it right now. We have not started that here. Is that when the disease is confined only to the liver, then one could consider using intra-arterial Lutathera. If the disease is systemic, meaning the lung metastasis or bone metastasis or pancreatic primary, we want to treat all of this area, probably intravenous approach is better. Second problem with Lutathera is that it is it's a dose that is not titrated towards the tumor volume. So that is something you need to work on moving forward if you want to do for the transarterial therapy. The liver dose is quite high. So some mechanism has to occur. What is the dose really required for these patients when you do intra-arterial therapy? We know in Y90 we need to get at least 190 gray, but is that true for Lutathera? Lutathera may not need that much, maybe less than that much. So we need to do some adjustments of those things. My belief is that you can do intra-arterial therapies only if the disease is mostly confined to the liver. And it might reduce the toxicity as well.
Thank you. Actually, thank you, Dr. Kalwa, for a wonderful lecture. And Dr. Bajal took one part of my question that I was about to ask you. I wanted to put it across again, a patient with having neuroendocrine metastases with a liver predominant metastases. So we always have this discussion in the MDT of using PRRT therapies versus Y90. And I believe I came across in some research regarding papers where they suggested that if the lesions are big and probably macro-sized, the Y90 does better. And if they're small lesions, micro-sized, I think the PRRT scores over it. So your thoughts and your experience regarding these two findings, I don't know if really it's true or not.
Yeah, great question. Actually, we went through this cycle of discussions in the last 10 years since PRRT was approved. When PRRT was approved, there is a humongous amount of excitement among the medical oncologists, and most of these patients were referred to PRRT the minute everolimus is no longer working in those patients. And what we have seen is a significant number of these patients developed bone marrow toxicity, very high liver toxicity. 6% of these patients developed bone marrow suppression. So PRRT is not now favored, at least in my institution. All these patients first get bland embolization only, and when they progress bland embolization, then they will get PRRT. The reason why we don't do Y90 for neuroendocrine metastasis is that to preserve future option of PRRT in these patients. Once you give Y90 to the liver, there is a very high risk of liver failure if you give PRRT on those patients. So that's the only reason we chose to do bland embolization, the first method, followed by later, if required, PRRT. When the patient is deemed ineligible to get PRRT for various reasons, then we can always do Y90 following bland embolization. So we do not offer PRRT the first line therapy when everolimus fails. They always get intra-arterial therapies first.
Thank you. Okay,
Thank you.
I think that brings to the end of this session.
Yeah.
And thank you so much once again, Dr. Kalwa.
Thank you, chairpersons and the speakers. Thank you.
Thank you.
Now, may I please call upon Dr. Ashok Chaudhary, Organizing Secretary, ILCC, to give his concluding remarks and words of thanks.
Thanks everyone for this 3 days of engaging talk on a small topic SCC. So for this I want to invite my organizing chairman Professor Manoj sir, please to the stage sir, and Professor Omata, who was, despite his busy schedule, gave time, endorsed this event as a apostle one, and hope his continued effort will continue with us. Sir, please. Professor Omata. And my co-organizing secretary, Dr. Satender, and Dr. Amar Mukund sir, he has continuously helped, and above all, for all this is possible only because of a single person, Professor Sarin sir, our mentor. He is a patron and who has made this event to go continuous with best of academics, best of innovations, and I hope we got feedback that you hugely appreciated by all circles in this era. So with this, I want to thank all our members of our organizing team, particularly Dr. Deepti, Dr. Pratibha with me, and all who are on the stage, our PhD and residents who are working behind the team continuously, and whole department of ILBS who has continuously working around the clock. Then not only the department of hepatology, it is a whole hospital, administrative team, support staff who are able to make that we have to be able to run 10 halls at a time for this pre-conference workshop, which is able to serve nearly 100 students who learn lot of things in this. So at the end, I thanks our event partner, M.I.E. and his team, and obviously many people who are behind, who are there, whom I cannot say that without their effort it can be done in flawless way. And with this, I request Professor Omata for his.
Thank you very much. Of my limited experience of the communication 40 years with India, I think this is the best conferences. Discipline, integrity, governance, and choice of the topics, and the choice of the moderators and the speakers. I think I was in Beijing, Korea, Tokyo, of course, then India in the just last 1 week. I was amazed about this meeting. Actually, I was in Beijing too. Of course, they are disciplined, but the quality is not comparable. It's amazing. 40 years, 50 years communication with India. I'm very happy to be here, to be present. Thank you very much, Ashok, and then everybody. Thank you very much. 谢谢.
I request all to please join on stage, the residents, the faculty, ILBS staff who has helped us, and the delegates who are there with us till so late. So please